Welcome to the pandemic-delayed GALA conference for Dallas in 2020. And thank all of you for coming, both here and online. We have, I think, some wonderful content for you over the next day and a half, and I hope that you get a lot out of it. I'm Larry Schiller. I'm one of the chairs for the conference this year, along with Mack Mitchell, who you'll see later on. All right, well, this is just a brief reminder of the history of this meeting. Dates back to 2013. We've been very fortunate to have a meeting in Texas each year, and we provide benefit not only to our local region, but also surrounding areas. This year, because of the pandemic, there are only two of these scheduled. Both were delayed from earlier, one that was in New Jersey a couple weeks ago, and the one today. The joint sponsors are the GI and Liver Association of the Americas and the Texas Liver Institute. We'd also like to thank our commercial supporters who make this meeting possible. That includes Shionogi, AbbVie, Intercept, Echosens, Gilead, Methodist Dallas, Prometheus, Salix, Takeda, and UCB. Those of you who are here can visit with some of the representatives of these companies during breaks. We'd also like to have a special thanks to AbbVie and Intercept for supporting the welcome reception this evening. So after the meeting, for those who are here, we'll have some brief refreshments at 5:30. Tomorrow at lunchtime, Intercept Pharmaceuticals is sponsoring a product theater. This is a non-CME event, but you're all welcome to listen to what should be a wonderful talk by Dr. Mantry. Tomorrow morning, we'll have some breakout sessions for those who are here at the site. There are 4 of these, and I hope you will go to the one that's assigned on the back of your card so that you can benefit from some closer interaction with these faculty members. As far as continuing medical education and continuing nursing credits, you need to go online for this, and you can go to livegala.org tomorrow afternoon and get the credits at that time. So keep that in mind, jot down any memorable items. We'll be taking questions in panels at the end of each session. These will all be on paper this year, so you should have some paper handy at your sites. Those of you who are joining us online can submit questions online, and they will be fed to the moderator so that we can get good answers for your questions. Again, we'd like to thank these sponsors for supporting the CME activity. Our educational objectives for the meeting are to be able to describe evolving patient management and treatment strategies for chronic liver diseases and GI disorders, to integrate significant advances in the therapeutic and diagnostic modalities into your clinical practice, and to apply the latest in clinical research, including anticipated therapies for the benefit of our patients. There are disclosures, and many of the individuals on the program have some interactions with commercial entities, and these are listed for you under each of the faculty members. Additional information, there is a pre-test that we usually do in person, but because we're both online and in person, this is going to be entirely online this year. So go to livegala.org to do your pre-test, and then at the end of the seminar, there'll be a post-test that you can conduct at that same site. And the slides and recordings from the program will be posted so that you can share them with your friends and colleagues. All right, well, I think that brings us to the last of the warm-up slides, and we'll now head into the first element of the program. And I'd like to introduce Dr. Nancy Reau, who will be joining us virtually.
Hello, I'm Nancy Reau, and I really want to thank the program organizers for inviting me to discuss hepatitis C, updates in screening, and black box warnings. The objectives of today's lecture are to review some of the changing epidemiology of hepatitis C, which has then reflected current treatment guidelines, and then discuss recent changes in screening, treatment indications, and some black box warnings. Here are my relevant disclosures. We're all aware of the WHO task for elimination, which requires a 90% reduction in new chronic hepatitis C infections, an 80% treatment rate in those that have active infection, and a 65% reduction in mortality rates. I think many of us are aware we're off target for most of these metrics outside of the 65% reduction in mortality, as prioritization for individuals with advanced disease and those with long-standing hepatitis C are easier to recognize. And that's pre-COVID. You can see from this easel presentation from 2019 that most developed countries are way off target for these elimination goals, with this slide demonstrating that 80% of high-income countries are not on track and 67% are off track by more than 20 years. Part of this is related to the subspecialist and the primary care provider relationship between the care cascade. You can see from this data that early screening and confirmation relies on your primary care provider or your non-specialist. But as a person transitions through the care cascade, it increasingly is dependent on the specialist to stage disease, engage in therapy, and then to confirm cure. Even before we start to talk about treatment, though, effectiveness of screening is quite poor. This is a study looking at the United States, looking at those states that are actually anywhere close to those WHO targets for screening. And you can see from this graphic that there is really only minimal states that are on target for the WHO 2030 screening recommendations. And in order for us to increase that, you're going to have a lot more identification of Hep C across the country. So why is screening so challenging? Well, I think a lot of this is related to the changing epidemiology. You can see from this graphic that shows the prevalence of hepatitis C between 2005 all the way to 2017, that we're transitioning from that birth cohort, that group of individuals recognized born between 1945 and 1965, to now a bimodal distribution. This bimodal distribution has been driven by the opioid epidemic, so that you can see that the acute infections are increasing significantly. And this is strongly superimposable against a graphic that shows the rates of opioid injection of any type, especially heroin. This has resulted in us having to change the screening recommendations. So in 1998, the CDC first published risk-based screenings. And these stood all the way until 2012, when there was a relatively contentious but effective movement to screen those that were in that high-risk birth cohort between 1945 and 1965. Thankfully, there's been a much more easygoing path to expand these to near universal screening. So the United States Preventative Task Force and the CDC, as well as IDSA, AASLD, all now recommend a one-time screening for anyone age 18 to 79. And because it has that B ranking, it should be covered by our insurers. The AASLD IDSA goes a little bit more granular. Not only do they recommend that one-time screening for nearly all individuals, but they also recommend at least a one-time screening for individuals younger than 18 that are engaged in high-risk factors. They also strongly emphasize that periodic repeat testing is necessary for those that continue to engage in high-risk factors or develop high-risk factors later in time. So obviously you can't screen someone at 18 who then doesn't engage in IV drug use until they're 21 and expect that that 18-year-old screen was effective. They also highlight those that are HIV-infected men who have sex unprotected sex with other men as a group that requires at least annual screening. And some of our guidelines actually recommend semi-annual screening for that risk group. Our treatment guidelines have evolved also significantly, with the most recently updated guidelines being the EASL's final guideline, as they call it, which was released in September of 2020. All three guidelines, AASLD, WHO, and EASL, recommend near universal access to treatment. EASL and AASLD do carve out a group of individuals that have a high risk of mortality that is not related or would not be modified by hepatitis C treatment as a group that may not warrant hepatitis C therapy. Outside of that, they strongly recommend access to treatment, which includes those that are actively injecting. They also recommend that our treatment is a pan-genotypic therapy. So although we used to have multiple options, we now recognize that over 99.9% of individuals can be cured through these pan-genotypic treatment options. And I'll give you some of the data for that, just a superficial look. This is at data looking at soft vel for 12 weeks across all genotypes. This study included people who were compensated cirrhotic as well as non-cirrhotic. And you can see that in this over 1,000 person cohort that the efficacy or the SVR rates were 98%. The AASLD does still carve out a little bit of recommendation for RAV testing in those that are genotype 3 with cirrhosis. EASL used to do that, but in the 2020 release, they now recommend really no genotyping and soft vel for 12 weeks or GP for 8 weeks, across the board, no RAV testing necessary. This is the data for glucapavir pibrentosphere for 8 weeks with and without cirrhosis. And then when you expanded, the original studies looked at 12 weeks of glucapavir pibrentosphere in those with cirrhosis. And just like soft vel, efficacy was very high across the board, 98 to 99%. This was then later looked at a shortened duration in those with compensated cirrhosis that included 8 weeks in pan-genotypic or all of our genotypes. And you can see that the rates of efficacy for a shorter duration were very high. And because of that, the FDA expanded the approval of 8 weeks to include treatment-naive compensated cirrhosis in September of 2019. And this has subsequently been reflected in both of our guidelines, both AASLD as well as the EASL guidelines. So this is a very superficial look at our EASL guidelines that were again updated just recently, September of 2020. And although they do recommend pan-genotypic therapy, either 8 weeks of GP or 12 weeks of soft vel in those without cirrhosis or with compensated cirrhosis, they also give a very simplistic approach to those that have limited resources, which means that you can really consider access to treatment if you can prove hepatitis C replication. And in our EASL guidelines, they do talk about core antigen testing for hepatitis C. That's not commercially available in the United States. And then they recommend assessment of fibrosis by non-invasive measures. If you can accomplish these two things, you can link a person to effective curative therapy. AASLD-IDSA also has a simplistic treatment algorithm. Now, it doesn't look that simplistic from where I cut and pasted it here, but if you look at the cheat sheet on the left, it really says that not only should the simplified treatment algorithm be applicable for the patient population, but also for a less sophisticated provider type. So it's not only simplifying therapy for the patients, it's also trying to expand the ability for a non-specialist provider to be able to treat the majority of hepatitis C. So in a treatment-naive non-cirrhotic population, which means that you have to exclude advanced fibrosis, you also need to do a med-rec to make sure there are not drug-drug interactions, which we'll get to later in the discussion, exclude co-infection with HIV and hepatitis B, and then recommend use of a pan-genotypic treatment, either glucapavir pibrentosphere or soft vel, minimal monitoring. Obviously, with this population, you shouldn't need to do a lot of monitoring because they're treatment naive and non-cirrhotic. And then do still assess for cure by obtaining an SVR 12 and then counseling them on risk reduction so you decrease the risk of reinfection. So a lot of words for really a very simplistic path. I want to come back. This is that same slide. You're not dreaming. You are seeing it twice, but I want to focus now on a slightly different subset within this bimodal distribution. If you can notice, the red bars are women and the dark blue bars are men. And in this new cohort, this new younger population, you can see that the male-female differences are really being eliminated. So what does this mean? This means that in this group of young individuals that have near equal opportunity between men and women for exposure to hepatitis C, that we have a lot of women in the United States that are of reproductive age and are also infected with hepatitis. And you can see from this notifiable disease surveillance system from 2006 to 2014 that this monumentally increased from 15,000 to 31,000 between 2006 and 2014. The prevalence of hepatitis C in this group is, variable by state. You can see that this graphic of the United States, which really reflects 2014, shows that there are places where the prevalence is incredibly low, such as Hawaii. And then there are places such as West Virginia where the prevalence is incredibly high. And so although this is, recommended for a pregnant population across the board, there are certainly places that are going to be more motivated to screen our pregnant population. Still, although the American College of Obstetrics and Gynecologists have not adopted universal screening in pregnancy, the CDC and the IDSA-AASLD strongly recommend that all pregnant women during each pregnancy should be screened for hepatitis C, as well as hepatitis B. What do they say about the antiviral therapy for prevention? So you are aware that with hepatitis B, there are strong recommendations to actually treat the hepatitis B in pregnancy for those that have high viral load to prevent maternal to fetal transmission or mother to childhood transmission. In the AASLD-IDSA guidance, it's still strongly emphasized that you should treat the hepatitis C pre-pregnancy. But the most recent update in 2019 did change the recommendations from no treatment during pregnancy to try not to treat during pregnancy. But despite lack of recommendations, treatment could be considered during pregnancy on an individual basis after a patient-physician discussion about the potential risks and benefits. So this is a big step. It means that you're not necessarily treating to decrease maternal to childhood transmission. You might actually be treating because this is the best opportunity to treat the mother as she runs the risk of not having effective access to treatment postpartum. And the reason for this, as you can see here, we think that maternal to childhood transmission is quite low. This is a big meta-analysis. It demonstrates in those that are HIV negative that the risk of a child ending up with chronic hepatitis C after being born to a mother with active hepatitis C is about 5.8%. It's higher in those that are HIV positive at 10.8%, but I'm going to outline in the next few steps that this is a gray area. The reason for that is the algorithm for testing in a child born to a hepatitis C positive mother is very prolonged. And if you think back on the original care cascade in the United States for adults, which requires an antibody to a hepatitis C PCR, confirmation, linkage to care with identification for those with advanced fibrosis before having access to treatment. And we saw those monumental drop-offs, even from screening positive to that confirmation test. It's easy to imagine how you're looking at a care cascade that goes over 3 years as being less than effective. So here our recommendations are to either first screen the child at 18 months of age with the antibody test, and if that's positive, then to obtain a PCR or a viral level at the age of 3 years. That's a big thing to remember for a group of individuals that might have some other psychosocial factors, weighing in. Alternatively, a PCR could be done in the first year, although they still do not recommend any linkage to care for effective therapy until a much later time. So I'm going to use Kentucky as an example as how well this works. So Kentucky is another state where there was a big increase in pregnant women having hepatitis C at the time of birth. So you can see that that this quadrupled between 2010 and 2016. However, of all the women that were screened, 80% of them did not have confirmatory tests. So 80% of women that had antibody had no idea if they had active virus at the time of birth. On top of that, of the children born to those that actually had confirmed hepatitis C, 78% of the children had no screening or no confirmation. So although we think that maternal to childhood transmission is low, it's definitely not based on large groups of evidence. Luckily, though, if you do have a child who ends up with chronic infection, there are increasing access to pan-genotypic treatments. So you can see this is looking at glucapavir per brintosphere. You can look at the efficacy on the right hand of the slide. Treatment efficacy or cure rates are just as high in the pediatric population as is in the adult population. And this is considered effective in children ages 3 to 12. We see the same or similar data looking at sofosbuvir-based therapies, and you can see this is looking at soft-vel for 12 weeks in a pediatric population. And again, efficacy is incredibly high. So although I've spent the last 20 minutes explaining how this is simple, it is still not thought-free. And when we think about adverse events, anyone who used interferon or our first generation of direct-acting antivirals recognize that the treatment side effects from today's pan-genotypic treatment is incredibly small compared to that, but it is still not zero. So severe adverse events in this top line are less than 10%, actually less than 5% most of the time, a little bit higher in those that have cirrhosis, but discontinuation due to adverse events is very low. Most of our adverse events are quite tolerable, headache and fatigue being the most common. And then there is a little bit of gastrointestinal, side effects in those at low rates with soft-vel Vox, as well as a little nausea in soft-vel. Sofosbuvir used to have warnings around those that had advanced kidney disease. However, this has recently been updated. Now with increasing safety and efficacy data, we recognize that sofosbuvir can be used in those with CKD stage 4 and stage 5. That's those that have a GFR less than 30. And this has been modified in our treatment guidelines as well as the package insert so that now both of our pan-genotypic treatments can easily be considered in patients with end-stage renal disease. But the FDA recently put an alert out in those that have advanced liver disease, considering a therapy that includes a protease inhibitor. Now, compensated cirrhosis is very safe to use with any of our treatments, including protease inhibitors. But if you have a person with advanced liver disease and decompensation, here there's a risk of liver injury because the metabolism of your protease inhibitor is different. It actually, leads to high efficacy because it has higher concentrations in the liver, but there is a higher risk of complications. Now, I'm going to go back in time. This is a large target database that was looking at some of our first treatments. You can see the therapies used here were sofosbuvir, ribavirin, Simsoft, ledipasvir soft, prod or paritaprevir, ritonavir, bidosvir, and desabovir, and decladisvir and sofosbuvir. And when they looked at nearly 5,000 individuals, and remember our first waves of therapies were enriched in those who had failed prior treatment, had cirrhosis, had a history of decompensation, a quarter of these individuals had decompensation. Very few of them had adverse events that were related to toxicity or discontinuation of therapy. But of those that had an increase in their bilirubin from baseline, this is where we started to see that hepatotoxicity or that risk of complications. And when we looked at treatment emergent drug-associated liver events, or DALE, 36 individuals had DALE, of which 94% were cirrhotic and 78% had a history of decompensation. So it really emphasizes, even in these older, longer duration therapies, that the group that's at higher risk for protease inhibitor-related side effects or treatment-related side effects were those that had much more advanced disease. So it emphasizes that you really have to talk about a patient, ask them if they had a variceal bleed. If they have cirrhosis, make sure you get that baseline ultrasound to make sure that they don't have ascites. So the other black box warning or safety alert is around hepatitis B reactivation. And this is not new. I'm just putting it in there as a reminder so that we don't, forget one as we concentrate on the other. The original alert, again, came because we didn't look at our patients carefully. So there were significant side effects or treatment complications related to Hep B reactivation. But almost every single individual that had one of these had very poorly characterized hepatitis B at the time they were engaged in treatment. It's also important to recognize that this is not new with DAAs. Interferon-based therapy had reactivation of Hep B associated with it also, just much later, because as interferon is also an antiviral, it was suppressing the hepatitis B reactivation. Here, with our direct-acting antivirals, the Hep B reactivation occurs much earlier as you shut down the Hep C, which is using the antiviral machinery, and now you'll allow the hepatitis B to start to replicate. When we look at this large database from the VA of nearly 63,000 individuals, you can see that those rates of Hep B reactivation are quite small. These patients were better characterized, and of these, very few of them had Hep B reactivation, although it did exist, and then it concentrated mostly in those that were surface antigen positive and had replication. So it just reminds us that if you have a surface antigen positive individual, look for the Hep B replication. If it's there, suppress the Hep B. If it's not there, you can either do prophylactic antiviral therapy for the hepatitis B, or you can monitor the Hep B viral loads, although the prophylactic therapy is going to be much more effective, as patients sometimes forget to get labs, and you don't want to have a missed opportunity where you can prevent something. So the last thing I'm really going to dwell on are drug-drug interactions. So you can see that frequency of contraindicated drug-drug interactions are relatively high. This is looking at about 4,000 mono-infected vets, so not our co-infected patients, which have a lot higher risk of drug-drug interactions. In this group of nearly 4,000 individuals, 20% of them had contraindications for at least 3 of our direct-acting antiviral therapies, and 2.3% had strict contraindications for all 4. So obviously, if you have a protease inhibitor, then you're going to have a little bit higher rate of a drug-drug interaction. But I want to pull your attention to this slide, which is a messy but colorful depiction from the EASL guidelines on these drug-drug interactions. The classes of drugs are on the top, and if you're green, there's really no significant concern. If you're orange, that's a cautionary tale, and if you're red, it's a strict contraindication. And you can see here from these breakdowns in these drug classifications that there is a fair amount of concern in our HIV therapy. So if you're on another antiviral therapy, you have to be very careful about your hepatitis C treatment that you're going to use. There are very nice green columns, which means that you should be able to find a therapy that fits in nicely with the ART treatment. Where it's more difficult is our anticonvulsants. There are some anticonvulsants that are really contraindicated across all classes. And if you can't switch the anticonvulsant to a different therapy, then that's going to be a patient that really is not going to be able to be treated for their hepatitis C, or at least not safely. There are the other cautionary tales, such as your antiplatelet and anticoagulants, and then your lipid-lowering drugs. So these are the big places where you really need to concentrate to make sure you don't have an anticipated drug-drug interaction. So our key takeaways are, number 1, improved screening and linkage care is imperative for us to achieve these WHO elimination targets, especially now with COVID and the pandemic, where we're seeing a disruption in some of these preventative screening services. Changing demographics have led to near universal screening. So do recognize that all of our treatment guidelines recommend screening from a one-time screen from 18 to 79. So really every single person that walks into your office, especially in adult medicine, should be screened at least once for hepatitis C. Treatment is safe, simple, and highly effective, allowing nearly all to be cured, and to expand our provider pool so that we really can start to move a lot of this outside of subspecialty care into primary care, or bring the therapy to the actual patients. But drug-drug interactions, staging, and special considerations in co-infection is still necessary to be able to treat our patients safely.
Good afternoon. My name's Craig McClain. I'm Associate Vice President for Health Affairs at the University of Louisville. And it's a pleasure to be here, if only virtually, at the GALA Symposium and talk about one of my favorite topics, which is ASH versus NASH, similarities and differences. So I have no disclosures related to this particular topic. So in the next half hour, we're going to present an overview of ASH and NASH, talk about diagnosis, just touch on mechanisms, then go into treatments and have a conclusion. So this is the front page of CMGH about 5 years ago, and a lead article that we wrote showing that there are many different ways of getting to steatohepatitis. So you can drink too much alcohol, you can have dietary indiscretion, or you can have environmental exposure, which we won't have time to talk about today. But all of them lead to one histologic phenotype. So why are ASH and NASH important? Well, if you look over the past 15 plus years, the mortality from liver cirrhosis due mainly to these diseases has increased dramatically by actually 65%. And the deaths from hepatocellular carcinoma have actually doubled. And in Kentucky, we're proud to be the leader in the country. So our annual increase has been 6.8%. So this is a big problem. So classically, when we think about phenotypes for ASH and NASH, we have these two guys here. And actually the guy with alcoholic steatohepatitis is from one of my VA cooperative studies. But increasingly, this is what we're seeing. And this is actually what we see in our recent NIH cooperative group, the DASH Consortium. The average BMI for our alcoholic hepatitis patient was 30. So it's BASH. It's both alcohol and NASH. And so we have people drinking more who are also overweight. Now, it's clear that even moderate drinking will increase fat in your liver, as shown in the Framingham study here, where you can see in blue, 14 drinks a day will cause fat in the liver. 21 drinks a day will cause even more. And very importantly, when you combine alcohol and either fructose or fat, you get a synergistic effect. So in this study, we fed mice either fructose or alcohol in low amounts, or then combined the two, shown in blue. And so with the combination, you get much worse liver injury. Now, part of that may be because fructose is metabolized similar to alcohol, and we'll talk about that a little bit here. Now, this is a study that'll never, ever be done again. So a fantastic article by Manny Rubin and Charles Lieber in the New England Journal in 1968. They took students from NYU and they put them in the Clinical Research Center at Mount Sinai Hospital, did amazingly a baseline liver biopsy, and then fed them alcohol for 2 weeks and did a follow-up liver biopsy. And as you can see here, everybody that was fed alcohol for 2 weeks got fatty liver. On electron microscopy, there were marked mitochondrial changes. And once they stopped drinking, the fat went away. Now, we probably see a lot of this in COVID. So there's a lot of drinking going on and a lot of mild fatty liver disease, maybe even more than mild. There's also the human model of NASH, and that's seen here where in the movie Super Size Me. And you can see that the patient's liver enzymes went up dramatically. So one of our GI fellows, when he was watching the movie, froze the frames when the doctor here was looking at the patient's chart and pulled off his liver enzymes. And they went up dramatically, which caused the patient to have to stop this whole experiment by supersizing in McDonald's. So it's important when we're talking about drinking to both understand how much you're drinking and the pattern of drinking. So a standard drink is 14 grams of alcohol. So that's whether you're a beer drinker, a wine drinker like my wife, or a bourbon drinker like me. A drink is a drink. Now, moderate drinking is considered non-harmful or maybe even helpful and healthy. And that's 1 drink a day or less for women. And the new standard is probably going to be 1 drink a day or less for men. It's currently 2. Binge drinking is 4 or 5 drinks on one occasion, depending on whether you're male or female. This is what we see in our patients with alcoholic hepatitis. They're drinking 13 to 15 drinks a day, which is incredible. This is over 2,000 empty calories a day, which brings into play the importance of nutrition in alcoholic hepatitis. Now, a somewhat analogous situation is fructose consumption. So my favorite drink here is Mountain Dew, which I love, but it's 290 calories that are basically empty nutritional calories. There's carbohydrate, but there's no protein, no fat, no vitamins or minerals. And fructose, as I mentioned earlier, is metabolized very much like alcohol. And there's a great article called Fructose, Alcohol Without the Buzz that goes into this in detail. Now, as you're all aware, we're in the midst of not only the COVID epidemic, but a obesity and NASH epidemic. So 1/4 of Americans have fatty liver disease. But it's not only Americans, as shown here in the blue. You see the same thing in Asia. In fact, in Asia, they actually have a little bit more NAFL. And so this is a worldwide problem. Now, the worst thing you can be is a taxi cab driver in Taiwan. And why is that? Well, you have environmental exposure there, sitting around exposed to all the exhaust fumes. You're not exercising, and you're eating a terrible diet. So all these factors come into play. Fortunately, if you're a hepatologist, no matter whether the COVID epidemic is there or not, you're going to be in business. So this shows what's projected to happen over the next decade as far as increase in liver disease is concerned related to NAFL and NASH. So these numbers are absolutely astounding. And this is something that we really need to work on combating. Now, an important thing, and something they ask on boards all the time, is the association between NASH and cardiovascular disease. So NAFL is a huge risk factor for cardiovascular mortality, as shown at the bottom here. You get endothelial dysfunction, and you get carotid intimal thickness. And again, major cardiovascular risk. As your fibrosis goes to F3 or F4, your liver risk also increases and your liver-related mortality increases. Now, normally when we talk about progression of fibrosis, we say it takes about 7 years for you to progress one stage. So going from, let's say, stage 2 to stage 3. But there's also a thing called the 20-20 rule, where about 20% of people will go from bridging fibrosis to cirrhosis and 20% from cirrhosis to decompensation in 2 years. And so there are people that have a more accelerated disease process that we need to be aware of. Now, there's also major mortality and costs associated with alcoholic hepatitis. I like this study because they looked at insured patients with alcoholic hepatitis. So theoretically, they had accessibility to health care. 2/3 died over this period of time, the 5 years, and 44% of them died in the first year. So huge mortality, and less than 500 were transplanted. So if we move on to diagnosis and look at liver histology, it is absolutely identical between ASH and NASH, whether you're talking about fatty liver, cirrhosis, or even HCC. You can't tell the difference in the etiology. But with ASH, we don't do a liver biopsy. So we do drinking history, we do MELDs, we do the AST-ALT ratio, and make a clinical diagnosis. On the other hand, liver biopsy is the gold standard for NASH. We exclude patients with a heavy drinking history. More and more, we're going to non-invasive tests and FibroScan. And hopefully we won't have to be doing the liver biopsies in the future. So for NAFL and NASH without a liver biopsy, it's a diagnosis of exclusion. So you want to obviously exclude excessive alcohol consumption. Environmental causes are important, but much harder to exclude. And then there are a variety of more rare things that cause macrovesicular steatosis, and then also things that cause microvesicular steatosis, especially mitochondrial toxins. In laboratory testing, we test for viral hepatitis, we test for alcohol-related liver disease, get maybe a GGT, or we could get a phosphatidylethanol if we wanted to. We look for autoimmune liver disease, genetic causes, and drug-induced liver injury. Increasingly, we're using non-invasive tests in NAFL. My favorite one up here is the FIB4. So it's incredibly easy to do. Just plug the data into your calculator and you get this information on all of your patients. I also tend to use elastography, FibroScans extensively. So shown here is your FibroScan, which is just a small portable unit that is, we actually have in every one of our hospitals right now. And you can get either a fibrosis stiffness score in kilopascal units, or you get a CAP score telling you how much fat is there. And what we try and do is do sequential non-invasive tests to cut down this intermediate zone here. And so we will be able to, with 2 or 3 tests, hopefully distinguish people with no fibrosis from more advanced fibrosis. Now, alcohol-associated hepatitis is really a clinical diagnosis based on our history and biochemical criteria. And these are a set of criteria that was developed by a NIAAA funded consortium on alcoholic liver disease. But we need good biomarkers for alcoholic hepatitis. And I'm showing you this to emphasize something I think a lot of people don't really get. And that's how worthless, or certainly of limited value, the AST and ALT level are. So I have 2 groups of people here. In red are patients in an alcohol detox program with normal bilirubins, normal albumins, and I've separated them into ones with normal ALT or elevated ALT levels. In black here are patients in our alcoholic hepatitis study admitted to an intensive care unit. So our people in the detox program with elevated ALT levels have higher ALT than people dying in the intensive care unit. So this is not a good marker in alcoholic liver disease of severity of liver injury. What we think will be a good marker is the cytokeratin or keratin 18 level, which is a biomarker of cell death. So remember, ALT just looks at injury. This is a marker of cell death. And the M65 is a marker of actual necrosis. And as seen here, over 2/3 of people with alcoholic hepatitis have levels above 2,000, which is a cutoff for absolute histologic diagnosis of alcoholic hepatitis. And everybody's above the normal upper limit of 500. Now, the K18 to ALT ratio is also very helpful in distinguishing NASH from ASH. So remember, with NASH, your ALT goes up a little bit, your K18 goes up a little bit. In alcoholic hepatitis, your K18 goes up dramatically and your ALT doesn't go up at all. So the ratio markedly separates out alcoholic hepatitis from NASH. And it's really, as seen here under the ROC, totally diagnostic. What about mechanisms of alcoholic liver disease and NASH? Well, they're very, very similar. And there are a host of different mechanisms that can lead to steatohepatitis. Some are more important in some patients than others. And so this is one of our problems with drug development. So if you have a drug that's particularly effective against fructose-induced NASH, it might be less beneficial in McDonald's-induced NASH. And so I think we're going to see more and more personalized medicine and companion diagnostics in the future. And what we're going to talk about here is just one mechanism, which is gut permeability and endotoxemia. So shown in this cartoon, both alcohol and fructose or fat cause gut barrier dysfunction and gut dysbiosis. Gut-derived products or bacterial-derived products like endotoxin leak across. Actually, bacterial-derived metabolites can also leak across and cause inflammation in the liver, activate the toll-like receptor system, and cause cytokine production. Now, if we look at alcohol, if we take intestinal epithelial cells in culture and apply increasing amounts of alcohol, the epithelial resistance, or TER, goes down, showing that the gut gets leaky. If we look at patients going into a detox program, they have low-grade endotoxemia, so their plasma LPS is elevated, and it goes down as the patients dry out. The ones with the highest endotoxin levels are the ones with minimally elevated ALT levels. Now, this is why we like to give probiotics in our group to people with mild alcoholic liver disease, because we think it improves gut barrier function and liver disease. So as shown here, giving the specific probiotic Lactobacillus GG decreases the endotoxemia, causes hepatic TNF to go down, neutrophil infiltration to go down, liver enzymes to improve, and the fatty liver gets better. Moreover, when we gavaged alcohol-fed mice with GFP E. coli, so E. coli that fluoresce, the animals that got fed alcohol, you can see the bacteria translocated across to adipose tissue, because we've cut adipose tissue out and have cultured it here. And that didn't happen in the animals that got fed the LGG. So it totally fixed gut barrier dysfunction. You see a very similar thing in fructose feeding. So in fructose feeding, as shown in the black bar here, you get endotoxemia. When you feed the animals a non-absorbable antibiotic, you block the endotoxemia, and as shown over here, you also block hepatic triglycerides, and I'm not going to show you, but you also attenuate liver enzymes, hepatic TNF, etc. So what about treatments? Well, there are similarities and differences here. So everybody in both groups of diseases should get lifestyle modification. It's just different lifestyle modifications, and we'll talk about that. Both groups should probably get nutrition therapy. Again, different nutrition therapy. A subset would get drug therapy. Unfortunately, we don't have great drug therapy at this point, and there is no FDA-approved therapy for either one of these diseases. Only a small subset of people will get liver transplantation. So as shown here, alcohol use disorder patients with liver disease are optimally treated in a team approach. And this is because if you look at mortality, if somebody's hospitalized with alcoholic hepatitis and they die 6 months or so later, it's due to going back to alcohol and not from their initial alcoholic hepatitis. So we need to stop people from going back to drinking. What about nutrition therapy? Patients with alcoholic liver disease are frequently, basically almost always malnourished. Traditional nutritional support includes a high protein diet, very important, and a late night snack. And the late night snack prevents the person from going into a starvation mode overnight and breaking down muscle mass. So these guys don't have good glycogen stores in their liver. Nutritional therapy also attenuates many of the mechanisms of alcoholic liver disease, including gut barrier dysfunction. And there are multiple novel nutritional therapies that are being investigated, including those by our group. Inpatient management includes, again, optimal replacement of protein and calories, transfer to the intensive care unit, meticulous investigation for infection and treatment. Some people will get steroid therapy if there's no contraindications, but if they do, they should have the Lilly score checked at 4 or 7 days to make sure they're responding to steroid therapy. If they're not, the steroids should be discontinued. There's a NIH, NIAAA funded study that we're a participant in Louisville. Mack Mitchell is also in Dallas, where we're looking at prednisone as a control group. We did have GCSF as another group. That's been discontinued because of COVID and the enrollment problems that we've had. Our then major comparator group is going to be the group getting anakinra, which is a interleukin-1 receptor antagonist. And so we're blocking inflammation with anakinra. They get that for 14 days and they get zinc for 90 days. Therapeutic targets for alcoholic liver disease are shown here. There are multiple targets, and there are several new drugs that are being looked at, including IL-22, which gives liver repair and regeneration. It's also good for the intestine. DUR-928 has epigenetic effects. For moderate alcoholic hepatitis, we like the probiotic LGG or Lactobacillus GG. And some groups are giving a bovine colostrum that blocks LPS. And as we've heard about at the last couple of liver meetings, a liver transplantation is highly successful for some patients with alcoholic hepatitis. with outstanding 3-year survival patterns and limited return to alcohol abuse. Now, what about NAFL? Again, lifestyle modification, just a different lifestyle modification. So all my patients get the same lecture. Portion size, no sugared pops. Sugared pops, the easiest thing to get rid of. No fast food. Try and exercise 3 to 5 times a week. I like recumbent bikes or ellipticals. Some people can do water aerobics. I take my coffee into the room. I drink probably at least 10 cups a day. Coffee's good for your liver. I show people this pyramid. If you can lose 10% of your weight, you can actually reverse fibrosis, which is a critically important concept. Weight loss will probably be better than any drug that comes out. We know that for people with early NASH and NAFL, that vitamin E helps get fat out of the liver, 800 international units a day. But as seen here, the patients need to stay on it once they go off the vitamin E, why the liver enzymes go back up. I made this slide out for the original GALA symposium that was supposed to be held a few months ago. Several things have happened since then. Elfibranor, which was, I thought, a very promising agent, a dual PPAR agonist, did not fare well in phase 3. Probably, as you all know, obeticholic acid we thought would be the first drug that was released for NASH. It's not released yet. Its fate's very unclear at this point. Sineseveroc, a CCR2, CCR5 inhibitor, is still in phase 3. The galectin inhibitor may be beneficial for portal hypertension. Thyroid receptor studies look promising. There's a sterol CoA desaturase inhibitor that also looks promising and is also going to be paired up with one of your thyroid hormone receptor agonists that are specific for the liver. The thing that we're not going to talk about today that's really scary are the environmental risks. So there are a host of environmental toxins. You can talk about arsenic, you can talk about PCBs, as I'm going to show here. They all can induce fatty liver on their own, but they synergize with both dietary indiscretion, so NASH, or with alcohol and cause severe fatty liver. So in an experimental animal model, we gave PCBs here, which cause visceral adiposity and low fatty liver. High-fat diet does the same thing, but the high-fat diet and the PCBs basically causes marked visceral adiposity, and as seen here on oil red O, the liver just explodes. So in summary, ASH and NASH remain major health problems. Severe alcoholic hepatitis still causes greater than a 30% mortality at 3 months. Abstinence and aggressive nutrition support are the cornerstone for alcoholic hepatitis and ALD therapy. 25% of Americans have NAFL. New therapies are being validated as treatments for both of these disease processes, and transplantation is effective for both NASH and alcoholic liver disease, but only in selected patients, and we only have a limited number of livers. Thank you very much.
Okay, good afternoon. Thank you, Dr. McClain. I am Santiago Munoz from Drexel College of Medicine in Philadelphia, and we're going to go over the complications of cirrhosis in an interactive session with Dr. Mack from UT Southwestern. I wanted to thank GALA for inviting me to review this topic. This is a critically important aspect. We all see everyday patients with AKI, ascites, encephalopathy.
So Santiago, I'm going to just, I've got a separate set of slides here that I'm using as a backup. So thank you again for doing that introduction. And I hope all the audience can bear with us in terms of some of the technical challenges. But when we originally planned this talk, what we wanted to do is make this really more of a case-based discussion and point out along the way as we go through this case, some of the decisions that will have to be made in management. So Santiago, I'm going to tell you about a 51-year-old man who has decompensated alcohol-associated cirrhosis, and he's been requiring large volume paracentesis much more frequently over the last 6 months. So this time when he comes into the emergency department, he was confused, but he was hemodynamically stable, and he did have a large amount of ascites and peripheral edema. So next slide, please. So he was taking a number of medications, including both furosemide and spironolactone. He was also on propranolol, esomeprazole, ibuprofen as needed, and sildenafil as needed. He never used any injectable drugs, and he had stopped drinking alcohol about a year before his presentation to the emergency department. Next slide. So on examination, he was afebrile, his heart rate was 65, his blood pressure was 90/65, and he was oriented without asterixis. His lungs were clear. He had spider angioma, pulmonary erythema, splenomegaly, and a moderate to large amount of ascites with 3+ edema. Next slide. His white cell count, hemoglobin, and platelets were all below the normal range, and his serum albumin was extremely low at 1.9 grams per deciliter. AST and ALT were modestly elevated, and the creatinine was 1.76 with an INR of 2.3 and a sodium of 132, yielding a MELD sodium score of 27. Next slide. So an ultrasound of the abdomen was obtained, and it showed that he had a small nodular liver with splenomegaly and a large amount of ascites. They could see both the portal and hepatic veins were all patent. So Santiago, at this point, I'm going to ask you to tell us where you would like to go next in evaluating this man. So I'm going to turn everything back over to you now.
Yeah, this is, of course, a patient with a high MEL score that is experiencing signs and symptoms suggestive of spontaneous bacterial peritonitis. So the first item to clarify is, when do we perform a paracentesis in cirrhosis? And referring to the guidelines from our professional society, indeed, every time that we admit a patient with cirrhosis, we should perform a paracentesis. Whether the admission is directly related to the ascites or not, we need to do a paracentesis. The reason for that is that the studies have shown that about 10% of hospitalized cirrhotic patients do have an SBP, yet they may be in the hospital because of encephalopathy, AKI, variceal bleeding. This is not always done, this paracentesis in admitted cirrhotics. And in fact, in our own liver unit, we have a quality assurance program that measures how compliant we are with that. Because indeed, in the real world, a patient may be admitted at 6 p.m. for HE, and paracentesis is not done, even though the patient has substantial ascites. So every time that a patient with cirrhosis is admitted, we need to do at least a diagnostic paracentesis. The diagnosis of SBP, you are all familiar with that, is a white cell count greater than 250 polis established the diagnosis. Most SBPs are actually culture negative. So the diagnosis of SBP is not based on waiting 48 hours for a culture to grow up some form of bacteria. We do need to keep in mind the possibility of secondary bacterial peritonitis. That is in the non-cirrhotic patients, something that we see when a diverticuli ruptures, the appendix rupture, any hollow viscous perforation. In the cirrhotic patient who often is undergoing repeated large volume paracentesis as an outpatient, sometimes the needle nicks the small bowel, the colon, and that person may reappear in the hospital with secondary bacterial peritonitis. When is that we think about that possibility in contrast to SBP? When we have a patient with an unusual severity of abdominal pain, or when the white count in the fluid is very, very high, let's say 3,000, 5,000, 10,000 WBCs in the ascites, has to put in our mind the possibility that that patient may be having secondary peritonitis as opposed to SBP. And the way to confirm that is to call the lab and ask them to add a couple of markers that should not be present in the ascites because they are gut intraluminal markers. And I'm referring to CEA, amylase, and alkaline phosphatase. The ascites should be very poor in those markers. So if you do have a very high alkaline phosphatase or CEA, or amylase, for instance, in the fluid, that's a strong indication that the patient may be having secondary peritonitis. Because these microperforations a lot of times don't release a lot of air into the abdomen, your flat plate may not show free air as in a thick perforation, for instance. So the management is, of course, we're going to get not only the antibiotics on the patient, but we probably are going to want a surgical consultation standby. The antibiotics consist of third-generation cephalosporins intravenously for 5 days. There are some studies suggesting that one could treat SBP with oral antibiotics, but the standard of care is really intravenous third-generation cephalosporins. And I did discuss the issue of secondary peritonitis. Well, the paracentesis show in this gentleman a high SAG, which is indicative of portal hypertension, and a white cell count of 980 with 70% PMNs establishing the diagnosis of SBP. The next step in management here would therefore address not only the bacterial infection, but also the fact that the creatinine in this patient was found significantly elevated at the 1.78 level. And by the way, while we wait for the next slide, I should say that there's not a reason to check SAG every time that we tap a cirrhotic patient. That's a marker of portal hypertension that is not going to change. However, there is a need to check the cell count each time that these patients come as an outpatient for a large volume paracentesis. So let's talk about AKI in cirrhosis. This is an extremely common complication in our end stage patients. We're going to go over the types, the frequency, and the management. The traditional criteria from several years ago spoke about AKI once the serum creatinine reached 1.5 milligrams per deciliter. But more recently has been recognized that that's a very high threshold. In other words, we were making the diagnosis very, very late of AKI in cirrhosis. So the most recent criteria by the professional organizations indicate that AKI diagnosis begins when the serum creatinine increases at 0.3 milligrams per deciliter or doubles from the baseline obtained within 7 days. If we don't have a baseline creatinine within 7 days, obtaining the lowest serum creatinine within 3 months of that admission is an adequate baseline. So you can see that if a cirrhotic patient has a baseline creatinine of 0.6 milligrams per deciliter and appears in the hospital with SBP and the creatinine is now 0.9 milligrams per deciliter, that patient is actually having a stage 1 AKI. And the beauty of recognizing kidney dysfunction in cirrhotics so early is that the interventions can readily reverse the AKI and prevent this patient of moving into AKI stage 2 or 3, or the infamous hepatorenal syndrome. The severity of AKI is graded at the stage 1, which is 0.3 increase, or the stage 2 when there is a doubling or tripling of the baseline creatinine, and stage 3 is very advanced AKI, where the serum creatinine reaches 4 milligram per deciliter, or the patient requires renal replacement therapy. What is the importance, the clinical importance of recognizing AKI early in the clinical course? Well, there is a very close link of the survival and mortality of patients with cirrhosis in relation to the development of AKI. And you can see here that even with AKI stage 1, the survival is already decreased at 90 days. With the stage 2 and 3 AKI, the survival is dismal. And the reverse occurs with the mortality. Mortality increases with the very minimal AKI, which is a stage 1, and stage 2 and 3, of course, have a much greater mortality in the order of 60%. So that is the clinical importance of recognizing AKI before the thresholds from the old times, which require 1.5 milligrams of creatinine, or for HRS, 2.5 milligrams of creatinine. The pathophysiology of AKI-HRS, and AKI-HRS is the relatively new term for type 1 hepatorenal syndrome. So we have changed the terminology. The old terminology is HRS type 1. The current terminology is AKI-HRS. For type 2 HRS, that's the old terminology, we now refer to CKD-HRS, precisely because of the chronicity that you recall was associated with type 2 HRS. In any event, the pathophysiology involves the hyperdynamic circulatory state of cirrhosis with the splanchnic vasodilatation that leads to systemic hypovolemia. And in addition, you have the bacterial translocation as well as the production of dumps. All of these cytokines and molecules contribute to an inflammatory state, which ultimately causes tissue injury in the kidney associated with the ischemic injury to the kidneys. And the most recent data suggests that in HRS type 1, the heart has a role that is quite important. In other words, when patients develop HRS-AKI or type 1 HRS, several studies have shown that the cardiac output, which typically in cirrhosis is high, has begun to decrease. In other words, it seems that at some point, the heart of these advanced cirrhotic patients begin to get tired, the cardiac output decreases, and these patients run into severe AKI, leading to HRS type of AKI. The AKI in patients with cirrhosis comes in 3 large groups. The first one is pre-renal, second one is intrinsic kidney disease, and the third type of AKI in a cirrhotic patients is post-renal or obstructive. So the pre-renal is typically either hypovolemia or the hepatorenal syndrome. Intrinsic renal disease could be a GM or interstitial glomerulonephritis, any kidney disease there. The importance of this slide is that if you look at the hypovolemic type of AKI, it is often related to some of the therapeutic interventions that we are concurrently doing for these patients. So for instance, our patient with AKI may have been on too much diuretics. Our patient may be experiencing a variceal hemorrhage, or maybe the patient is being overtreated with lactulose, leading to a hypovolemic state. The other common cause of AKI is a patient that is having repeated large volume paracentesis as an outpatient and receiving no albumin or insufficient amounts of albumin. That ultimately leads to pre-renal AKI. If you recall, our patient in this case presented to the hospital with a very low serum albumin, 1.9 grams per deciliter, suggesting that maybe that patient was not receiving appropriate albumin during his outpatient paracentesis. When AKI is HRS, and this is probably, in my opinion, the most important slide of this part. It used to be in the old times, the diagnosis of HRS was quite complex. We had to measure urine osmolality, FeNA, excretion, etc., etc. It is now much simpler. And for that reason, I want to go over this slide carefully. First of all, we're going to have a diagnosis of AKI, an increase in creatinine. Secondly, we're going to do a plasma volume expansion with albumin, not with normal saline. 1 gram per kilo per body weight up to 100 grams for 2 consecutive days. Either the patient AKI will reverse, indicating it's not HRS, it's just a pre-renal hypovolemic AKI, or the patient is not going to respond, in which case the patient is now on track to have a diagnosis of true HRS. They cannot be shocked, neither current use of nephrotoxic drugs, and if you recall, our patient was taking NSAIDs, so his increased creatinine could be related to NSAIDs-related acute nephropathy. And on the urinalysis, we shouldn't really see any signs of intrinsic kidney disease, even by the absence of significant proteinuria, hematuria, and ultrasound of the kidneys showing no obstruction and normal size kidneys. It is after these steps then that we may be in front of a true legitimate HRS. And Guadalupe here look at a large series of hospitalized cirrhotic patients with AKI and find out that about 2/3 of these patients with AKI were related to hypovolemia or infection, and only 1/3 those who were not responsive to albumin support of the volume were true HRS type 1 or HRS2. So the probability of having HRA when we see a cirrhotic with AKI is for HRS approximately 1 out of 3, and for hypovolemic or pre-renal AKI about 2 out of 3 with the corresponding therapeutic implications. So what is the management of AKI HRS? This is the type 1 hepatorenal syndrome. We're going to stop the offensive agents, ACE inhibitor, vasodilators, including calcium channel blockers, ARBs, PDE5 inhibitors, and other nephrotoxics. We're going to stop the diuretics in these patients because of the volume implications. If the patient has been having diarrhea, obviously we're going to implement a holiday in the lactulose, as well as a beta blocker discontinuation, at least until that AKI reverses. And we're going to support the intravascular volume primarily with the intravenous albumin. Whether to use 25% or 5%, we can discuss in the question and answer sessions. We tend to use the 5% when the patient on physical examination is clearly dehydrated, namely you have a high MELD cirrhotic patient with no edema and no ascites. By definition, that patient is dry and is going to need not only colloids, but also some salt and water. And eventually we may need to use a vasoconstrictor. For many years, we all have been using midodrine. We really have not been impressed with midodrine all this time. But there are some options such as norepinephrine, and I wanted to show you some relatively new information on a more selective vasoconstrictor that is the terlipressin. This is a prodrug of vasopressin that is a very quite selective vasoconstrictor of the splanchnic territory. And if you recall from the pathophysiology slides, the problem here begins with the splanchnic vasodilatation, with pooling of blood in the splanchnic territory, leading to systemic hypovolemia. So with terlipressin, we can squeeze, vasoconstrict that abnormally vasodilated splanchnic territory and therefore restore to some extent the systemic volume status. Let's move to the next one. And terlipressin was evaluated in at least 3 large clinical trials in the US. I'm going to just show you briefly the top of the line results. By the way, terlipressin is approved in most countries in the world for more than 10 years. We still need to get this drug here to help our patients. This was a study of patients with hepatorenal syndrome type 1, and they included 300 patients, which is a very large number of patients with HRS type 1. The patients were treated for up to 14 days until they reached some of the endpoints that are outlined in the slide. The most important endpoint was to achieve a verified, confirmed reversal of the HRS type 1. Let's see how often that happened. And you can see that the studies show that in the group randomized to terlipressin, there was a double of number of patients that achieved confirmed reversal of the HRS versus the control group, where that event occurred in about 15%. Was that durable? After the 14 days of infusion of terlipressin, did the creatinine start going up again? And the answer was no. You can actually see that a few more patients had a response at 30 days from the infusion, and now the numbers are almost exactly double of reversal of HRS type 1 for terlipressin versus the control arm. So we're going to go back to this patient here. 5 days later, this gentleman was treated for SBP. The platelet counts had decreased to 31,000, but he is otherwise stable. The patient was very concerned about coming to get paracentesis again twice a week, which he had been doing. And TIPS was recommended, but the radiologist declined to perform the procedure because the platelets, the thrombocytopenia was severe at 31,000. What are the options here? Well, the thrombocytopenia and cirrhosis is very common. I don't need to tell you that this is something that we see essentially universally in patients with advanced cirrhosis. The mechanism of thrombocytopenia are outlined here, basically include a decrease in thrombopoietin production by the sick liver cell. There is a splenic sequestration, probably the primary mechanism, but there is also bone marrow suppression of the thrombogenesis, either by virus, hepatitis C, or by the alcohol in the case of the patients with alcoholic liver disease. And there could be also factors related to infection and immune-mediated thrombocytopenia. For decades, we have used platelet transfusions to support patients with thrombocytopenia due to cirrhosis when they confront invasive procedures. But we all recognize that the platelets in these patients have a very short duration. And when we use these platelet transfusions in patients with severe thrombocytopenia, we often see that the result doesn't get you to the 50 to 60,000 level, which is a quite common threshold to perform TACE or the liver biopsy or any other type of invasive procedure. So we are in that situation quite often. In addition, platelets can have a number of adverse events that I'm not going to go over here. And so patients with cirrhosis get into these difficult situations, as studies have shown that they may need anywhere from 1 to 3 invasive procedures per year. But when they have severe thrombocytopenia, the clinician is stuck there because the platelets transfusions are not able to correct this oftentimes to a level compatible with the invasive procedure. That is the novelty that led to the development, clinical trials, and approval of 2 TPO receptor agonists. This really has been, in my opinion, one of the breakthroughs in the practice of liver disease. They mimic the effect of thrombopoietin, which is decrease in cirrhotics. They are orally administered, and they actually bind to a different region of the TPO receptor in the megakaryocytes, meaning that they don't compete with the endogenous thrombopoietin. They actually enhance the effect on the thrombopoiesis there. We have 2 available in the US, avatrombopag and lusutrombopag. And in the case of avatrombopag, there were trials, international trials, that address the effect of avatrombopag in patients with very low platelet counts below 40,000 versus platelet counts between 40 to 50,000. And you can see that the patients assigned to avatrombopag achieved the endpoint, which was increase in platelet counts or lack of having to rescue the patient after the invasive procedure with platelet transfusions. It was clearly and highly significantly greater compared to the group of cirrhotic patients who went to an invasive procedure but received placebo instead of avatrombopag. You can see here the effect on the platelet counts here. This particular product is administered for 4 days. These are pills, not parenteral. And after the 4 days, you can see how the platelet count increase. And they increase substantially. As you can see, the platelets are in between 40 and 50,000 or even lower, and they get in the 70 to 80,000, which is plentiful of platelets for many of the invasive procedures that perform in these patients. Subsequently, over the next 3 weeks, the platelet counts return to the baseline levels there. This graph always reminds me of the hepatitis C days, where we had to be concerned with thrombocytopenia caused by interferon, and we had to use some very early products to increase the platelet counts in cirrhosis, and the power of those products was very low. We might increase the platelet count in those patients by 10 or 20,000. But you can see here that they get easily into the 70 to 80,000. Lusutrombopag is the other TPO agonist that is fully approved in the US for use now approximately 2 years. And again, the endpoint is achieved clearly much more frequently in the patients assigned to lusutrombopag. The endpoint here is no need for platelet transfusions or rescue therapy following an invasive procedure, whereas the patients that assigned to placebo and not lusutrombopag, about 30% of them versus 65% of them. Let's see the next slide here. Just like with the previous TPA, this product is given for 7 days, and you can see the steady increase in the platelet counts near the 70 to 80,000. This is the window to perform the invasive procedure, and subsequently the return of the platelet counts within a month to the baseline level. So these are products that have a very important clinical utility in the day-to-day practice of hepatology. I'm going to just go back to the patient to say that 5 days later, the platelet counts is now up to 120,000 by him having received treatment with a TPO agonist. So we went back to our interventional radiologist and asked, what about tips now? I have fixed the platelets in the patient. The radiologist is very convinced with 120,000 and performs a TIPS for refractory ascites in this patient without any complications. But 2 weeks later, the patient is readmitted after he is found wandering in the house, markedly confused. He is slightly febrile there. The heart rate, you can see there, 65 per minute. Neurology, he has a flapping tremor. He is oriented to person and place only. The abdomen shows minimal ascites, indicating that the tips is widely patent. He has normal bowel sounds, and he has no lower extremity edema. So Mack, we now have this patient showing up with post-tips hepatic encephalopathy.
Okay, so, I never mind coming on service after Dr. Munoz because he's done a great job of fixing this patient's AKI, his hepatorenal syndrome, and even his thrombocytopenia, and gotten the tips placed. But Santiago, you left him with a little bit of confusion here after that tip. So let's have the next slide. So as I was taking a look at this patient, I decided we probably ought to check and look at the West Haven grading scale to see where he falls on this scale of severity of encephalopathy. And based on the scale that you see on the slide here, he would fit best with grade 2 encephalopathy. So he's disoriented at the time. He's had some inappropriate wandering around the house, et cetera. And he's got some asterixis. So this West Haven scale is very useful, and it's probably the most widely used scale for describing the extent of impairment in patients who have overt hepatic encephalopathy. Next slide, please. So overt hepatic encephalopathy, next slide, please. So overt hepatic encephalopathy occurs in some 30 to 45% of cirrhotic patients and up to 50% of patients following a TIPS procedure. Are we on the next slide yet? I can't see it on my screen.
There you are, Dr. Mitchell.
All right. We're on the one that says worsening cognitive dysfunction. At the bottom, characterization of HE stages. There we go. Okay, so as I was saying, overt hepatic encephalopathy occurs in some 30 to 45% of cirrhotic patients and up to 50% of patients following a TIPS procedure. We need to keep in mind that the covert or minimal hepatic encephalopathy is even more common than overt encephalopathy is, and that can be seen really in some 20 to 60% of patients with chronic liver disease. Next slide. So as you can see on this slide, there's a number of factors that can precipitate an episode of overt hepatic encephalopathy, but these same factors also likely contribute to the underlying pathogenesis of covert encephalopathy. Increased production of ammonia is due largely to gut-related factors, and those include not only gastrointestinal bleeding and excessive dietary protein, particularly red meat, and occasionally constipation. Portosystemic shunts, both spontaneously developing ones and those that occur following TIPS, allow unmetabolized ammonia to bypass the liver and directly reach the central nervous system. So also drugs such as opioids and benzodiazepines can contribute to encephalopathy through their interaction with specific receptor and neurotransmitter systems within the central nervous system, but also infections and occasionally malignancies can contribute. In the case of malignancies, that's probably through the development of spontaneous portosystemic shunts within the liver itself. Next slide. So compared to the previous labs for our patient, you can see that the albumin, the platelet count, and the creatinine have all improved in this man. And so the question is, should we get a serum ammonia? Next slide. So all the routine testing of serum ammonia has been part of what I would think most people consider to be the standard of care for decades. There's really no substantial evidence that the level of elevation in ammonia adds either to the diagnosis or to the prognosis in patients with encephalopathy. And it probably doesn't even correlate very well with the stage of encephalopathy. So really the primary utility of a serum ammonia is in patients who have metabolic encephalopathy, but have occult cirrhosis with normal liver enzymes or whatever, but don't have other clinical evidence of liver disease. And in those patients with occult cirrhosis, the serum ammonia can be diagnostic if they come in with a metabolic encephalopathy. Next slide. So we all recognize that TIP can cause both overt and covert encephalopathy. And when you look at factors that are involved, pre-existing encephalopathy can become worse after a TIPS. And patients who are older and those who have high MELD scores before a TIPS are also at increased risk. But what I think is interesting on this slide is to note the relationship between the use of proton pump inhibitors and the risk of developing hepatic encephalopathy. And as you can see here, it's a pretty significant increase in the relative risk in this population. Next slide, please. So our understanding of just what it is about liver disease that contributes to metabolic encephalopathy has been evolving over the last decade or more. We know that in addition to ammonia, there are pro-inflammatory cytokines, there's oxidative stress, there's nitric oxide, and all of these things seem to play a role, perhaps through their action on astrocytes and glial cells in the central nervous system. And there in the central nervous system, glutamate really acts as a scavenger to reduce the ammonia that gets in by producing glutamine. So glutamate plus ammonia leads to glutamine through an enzymatic reaction that's catalyzed in the astrocytes. But that particular reaction can also promote swelling of the astrocytes and is thought to contribute to an increase in intracranial pressure. Next slide. So without any question, the gut's really the primary source of ammonia because ammonia is a byproduct of the intermediary metabolism of bacteria. And the microbiota in the gut can be altered by alcohol, as Dr. McClain said earlier today, but it's also abnormal in patients with cirrhosis. So gut dysbiosis and a leaky gut barrier both contribute to encephalopathy in these patients. So now that we understand this role of gut dysbiosis as the primary source of ammonia, you can see the rationale for why antibiotics and other treatments such as lactulose might be beneficial in treating patients who have hepatic encephalopathy. Next slide. Now, the reason why our patients with chronic liver disease get admitted to the hospital are many, but readmission to the hospital also turns out to be usually due to one of 3 or 4 different things, which are listed on this slide. So we often think of ascites and bleeding as being the primary reasons for readmission, but as you can see on this table, hepatic encephalopathy and hepatorenal syndrome are actually much more likely reasons for their readmission. Next slide. So over the years, our therapeutic options for treating hepatic encephalopathy really have broadened. And as I said earlier, when we look at the pathophysiology of how hyperammonemia develops, it's logical that antibiotics have been used to treat encephalopathy. Originally, the non-absorbable antibiotic neomycin was one of the early treatments that was shown to be effective, but it had the side effects of creating both ototoxicity and nephrotoxicity, particularly in patients who already had some compromised renal function. So it was largely replaced by lactulose sometime in the 1980s. And although metronidazole and vancomycin have also been used in an off-label sense to treat this condition, rifaximin really is the only antibiotic that's currently approved for treatment of hepatic encephalopathy by the Food and Drug Administration. Next slide. So let's come back to our patient. So after a few doses of lactulose, his mental status cleared, and within 48 hours, he was now oriented and ready for discharge. So now we need to think about what we're going to recommend in terms of his future management. Next slide. So over a decade ago, this pivotal study that's reflected on the slide demonstrated that adding rifaximin to lactulose would reduce the time to the first breakthrough episode of hepatic encephalopathy if you compared that to lactulose alone in patients who had been admitted to the hospital for their encephalopathy. And that 58% reduction was highly significant and was also associated with an improvement in the quality of life for these patients. Next slide. So as you can see on this slide, the time to first hospitalization was also reduced in patients who were treated with combination of rifaximin and lactulose compared to lactulose alone. And although it's not shown on this slide, the costs associated with readmission for hepatic encephalopathy were also lower in this group receiving the combination of rifaximin and lactulose compared to lactulose alone. Next slide. So the American Association for the Study of Liver Disease issued practice guidelines back in 2014 to look at how to manage encephalopathy. And lactulose was recommended as the first-line treatment, both for correcting overt encephalopathy and preventing recurrence of encephalopathy after the initial episode. But they also recommended that rifaximin be used as an add-on treatment to prevent recurrent encephalopathy. However, there was no recommendation by AASLD to use prophylactic treatment with either lactulose or rifaximin. So if the hepatic encephalopathy episode is clearly related to an acute infection or an upper GI bleed, you can treat the episode and then discontinue the treatment once that episode and event's resolved. But the strength of these last two recommendations isn't quite as great as it is for the first two recommendations. Next slide. Now, we're frequently confronted with patients who have mild cognitive impairment who don't have disorientation or asterixis. So this is minimal or covert encephalopathy. It's a lot more common and more commonly recognized unless you go through the effort of performing specific tests to either highlight deficits or you get additional corroborating information from family members. As you can see on this slide, both lactulose and rifaximin were effective in treating minimal encephalopathy when compared to placebo. Interestingly, there was also a benefit for both probiotics and the ornithine salt of L-aspartate when compared to placebo. However, when you compare directly to the standard of care, that is treatment with lactulose as a single agent, none of the other treatments, including rifaximin, probiotics, or branched-chain amino acids, proved to be superior. Next slide. So data from this same study indicated that both lactulose and the ornithine salt of L-aspartate were effective in preventing progression from minimal encephalopathy to overt encephalopathy, which confirms the importance that lactulose plays in treating this particular population of patients. Next slide. So let's now finish up and come back to our patient. So we've now reviewed all of the best evidence that suggests that a combination of rifaximin and lactulose is going to be the best thing to prevent recurrence, both to treat his minimal encephalopathy and also to prevent recurrence of overt encephalopathy. But there's no good reason here to continue esomeprazole, and it could increase the risk of both encephalopathy and infection, so I think it should be discontinued. And then finally, we should probably also discontinue propranolol and diuretics because, as Dr. Munoz pointed out for us, both of those treatments could compromise his intravascular volume status. So lastly here, next slide, our take-home messages. Hopefully you've seen now the evidence that patients with cirrhosis are at risk for both minimal encephalopathy that can compromise their quality of life, and that treatment of this condition should include both rifaximin and lactulose to both treat the minimal encephalopathy and to prevent recurrence of overt encephalopathy. And then finally, as Dr. Munoz has shown us, treating AKI hepatorenal syndrome requires albumin. And in the future, we may be using agents such as terlipressin to increase splanchnic vascular resistance. And then lastly, I think he's also given us a lot of evidence that the thrombopoietin agonists are useful in increasing the platelet counts prior to invasive procedures, and that could potentially minimize the risks of bleeding in these patients who often have severe thrombocytopenia. So I hope this has given you a way to look at patients with cirrhosis, the number of complications that they develop, including the ones that are most frequent, such as AKI, hepatorenal syndrome, thrombocytopenia, and hepatic encephalopathy. So I think at this point we'll finish up, and I'm going to turn the controls back over to Dr. Munoz, and I believe we are on time or a little ahead of schedule for our question and answer period. Thank you.
Thank you, Mack. We are going to have then time for questions and answers. We have a number of questions that have come online, but wanted to give a preference here to you guys that are attending live here, if there are any questions. While we set that up, we have a couple of questions for Dr. McClain and also for Dr. Mitchell. Let's start with the Mack question for you. Do you ever see, Mack, a scenario for rifaximin monotherapy for prophylaxis of recurrent HE? Or it always has to be used with lactulose?
Santiago, I think that's an excellent question. It does bring up one particular issue that I didn't go into detail on, and that is, while the data that we have are most convincing for the combination of lactulose and rifaximin, many of our patients come back to us after a period of time saying they just can't tolerate the lactulose because of the bloating and the other problems that it creates for them. I think we have to be careful in the way we dose lactulose. We certainly don't want to be dosing it to the point where patients are going to the bathroom every, several times a day, but rather, confine the dosing so that they have 1 to 2 soft bowel movements per day, particularly in those with the minimal HE. I often wind up with rifaximin as monotherapy because patients self-discontinue the lactulose, although I tell them if they ever miss a day, then they need to go back to the lactulose.
Thank you, Mack. I have a number of colleagues in my hospital that they tell me that, Santiago, I can smell my way to your office when I need to see you. The lactulose is really an undesirable drug. Question for Dr. McClain here that has to do with the Lilly score in alcoholic hepatitis. We have Craig online, I hope, at this point. The question is that there are some papers indicating that the Lilly score at day 5 of corticosteroid therapy of severe alcoholic hepatitis may be as predictive as day 7. And since there is always a pressure to send the patient home, can we confidently use the day 5 Lilly score to terminate the trial in somebody that appears to be a non-responder in that early time point?
So if Dr. McClain's not on, I can go ahead and try to take a shot at answering that. Craig and I have been colleagues working on both the DASH trial and also the current ALCHEP-NET trial for alcoholic hepatitis. And there's been a lot of interest in shortening the amount of time that it takes to predict when somebody is a responder or non-responder to steroids. And I think that in this instance, we're probably almost as predictive at 5 days as 7 days. But one of the ways that we've gotten around that is to simply give the patient a 7-day prescription for prednisolone, methylprednisolone, whichever drug you're using, send them home, and then have them follow up at day 7. I think there's a lot of value in that because both it shows the patient that you're serious about their illness, and you do have an opportunity to actually see them face to face as well as get additional labs at that day 7 time points. I'm still using day 7 more than I am day 5.
Yeah, so this is Craig. So we're talking about how long do we go on the Lilly criteria and steroids? Yeah. So I end up using day 4. I think day 4 is as good as 7, but Mack knows there's an article that's coming out in American Journal of Gastroenterology looking at keratin 18, which is a great biomarker for alcoholic hepatitis. It goes up with cell death. It's very elevated. And this comes out of the STOPA group from Great Britain. And they showed that a very elevated M30 K18 was the thing that you should use for your criteria for treating with steroids in the first place. And so if you only treated people with a level over 5,000, you would actually get rid of 80% plus of the steroid treated patients. So you get rid of all those side effects. So I think we'll have tests in the future that will predict who should go on steroids and who should.
That's a great point, Craig. I think this is the precision medicine that we're getting to finally in liver disease.
Exactly.
Okay, thank you. And I should just mention, last year we presented at ASLD our quadruple therapy for severe alcoholic hepatitis using prednisone, intravenous NAC, vitamin E, and orsodiol. And the thinking for that was that these patients are in true liver failure, and we don't have at the present moment a very effective therapies, and we can talk more offline on that. Question for Nancy. Nancy, the attendees would like to know if you would cure a male 18 or 16 patient, and there is a related question. Can you tell us what the effect of eradicating hepatitis C is on the natural history of HCC?
So the first question is much easier. I think that most of us will go up to a MELD of 20 or 25 and effectively eradicate the Hep C, knowing that the chance that they're going to get an improvement that would allow them to avoid transplant is high enough that that's worth it. And that 20 to 25, it's probably gray, and above a MELD of 25, then you could certainly cure them, but you should expect to still see them go to transplant. And that's going to depend on the rates of the ability to get a liver transplantation at a lower MELD in your area. I think that the second question is most challenging because we absolutely know, hands down, if you cure hepatitis C in a patient with compensated cirrhosis, you decrease their rate of developing a liver cancer. But we know that there are other factors that go into cancer rates, such as portal hypertension. I think over and over we see that FibroScan can predict rates of liver cancer. Gender, obesity, diabetes, age, concomitant alcohol use, Hep B, hemochromatosis. And if you have dysplastic nodules, you're much more likely to have those transition to cancer. And that DAA therapy probably isn't able to change that in that more immediate period. So I think that that's probably what drives some of these patients that seem to get very aggressive early cancer after cure. Whereas if you eliminate those patients, most of our patients are going to do much, much better with DAA therapy in the long run than not treating them because you're afraid that you're going to give them cancer.
Thank you, Nancy. We have another question for Craig. Is there any role for targeting anti-cytolysine and anti-candidolysine as potential agents for severe alcoholic hepatitis?
I think there's a potential role, but it certainly hasn't been evaluated in humans yet.
Yes, I might also add that some of this is based on some studies coming out of Bernd Schnabel's lab at UC San Diego. And he's shown that these bacterial and fungal toxins are important in pathogenesis in animal models. And he's also found the same toxins in stool from humans. But as Dr. McClain points out, we're not yet at the point where we can actually give bacteriophages in this setting. We are actually, there are some studies that have used bacteriophages, that is viruses that knock out selectively certain bacteria, that have used that for antibiotic resistant infections. And that's been shown by some other people at UC San Diego to be effective in that setting. So it may be safe, but it's going to be a few more years before I think this gets through the FDA review process. And
it actually looked like there was only a subset of people where it was going to be important. Yeah. I think the real thing is the gut-liver axis is huge in alcoholic liver disease. And I think we're going to see just a host of agents coming out that target the gut-liver axis. And so it's not only going to be endotox, and it's going to be all the bacterial metabolites that cause not only liver injury, but as you talked about, hepatic encephalopathy.
Thank you. There are a couple of questions related to my topic. What about albumin as a component of the therapy of SBP, and any role for PPIs there? That's an excellent point. It was not in the slides that the standard of care of treatment for SBP include the use of albumin at 1.5 grams per kilo on day 1, and then repeat at day 3, this time with a dose of 1.0 gram per kilo. So that's an important point of the treatment of SBP. And in regards to the use of PPIs, it's also correct. And just like for hepatic encephalopathy, epidemiological large-scale studies have shown that use of PPI is a risk factor for developing AKI and CKD. And that is true not only for liver patients, but for all kinds of patients. So we need to re-evaluate the indication for PPIs every time that we see our patients in the office, because oftentimes they get stuck with a PPI for no clear reasons. There's another question here for Dr. McClain, and this comes from Dr. Gish. He is questioning why to test hepatitis A IgM antibody in fatty liver patients when we are aware that this is a marker for immunity, and in order to allocate patients to immunization or no immunization, it would make more sense to use total antibody or IgG antibody rather than IgM. Could you clarify that, Craig?
Yeah, so really what you're looking for there is in your NASH patients, you want them to be immunized against hepatitis A and hepatitis B because they theoretically would get a worse course if they got either disease process. So it's really for immunization purposes.
Thank you. Nancy, what can we do about insurance companies, including state Medicaid programs, who will not approve treatment for Hep C in non-cirrhotic patients?
So I think that the easiest answer is that be patient. A lot of these states are improving. I mean, Illinois used to be a D- F+ state, and now we're an A- state. Restrictions are now based only on provider type and none of the other factors. It's easier in a person who doesn't have insurance. Every one of the companies have altruistic options to get access to treatment. You just have to be able to make sure that they can be monitored safely. And with minimal monitoring algorithms now, you don't need a lot of labs to prove that a person is able to get cured safely. And then using your FQHCs, sometimes there are ways of getting access to treatment based on allocations on your income, but it is frustrating. There are states where there are still considerable restrictions, and I don't think that we have a clear-cut way of getting equal access to treatment across the US.
Thank you. And Craig or Mack, there is a question, is there still any role for pentoxifylline in severe alcoholic hepatitis?
So I think there's a role for something like pentoxifylline. So the issue with pentoxifylline, we do a lot of work with PDE4 inhibitors, and actually we are interacting with industry on several of these. So I think they have great anti-fibrotic and anti-inflammatory potential. The problem with pentoxifylline is you're right at a therapeutic window when you reach GI side effects. So it's almost impossible to get the blood level that you need without a lot of nausea and vomiting. So people literally have to take it every day, 3 times a day, and then you're right at the lower limits. So we actually give it to our cirrhotics for anti-fibrotic effects, and we give it to a lot of our NASH patients too. I think for alcoholic hepatitis, it has some potential benefit, but it's basically is a weak anti-TNF.
Anything to add, Mack? We all are aware of that large English trial, more than 1,000 patients where pentoxi performed.
So in the,
as well as
in the STOP-AH trial, it did not improve mortality, and that was a trial that included over 1,000 patients. But as Dr. McClain's pointed out, conceptually, this is still an important and interesting target for future treatment. We saw in the trial that Craig and I were involved with, in the DASH trial, that the dropout in the non-compliance rate for pentoxifylline was more significant than for any of the other elements in that trial. So patients just won't take it because of the nausea and vomiting.
Right.
Thank you. Are there any questions from the audience? We all appreciate your attention. I certainly have learned a lot myself from my colleagues, and we will reconvene in this room at 3:15 p.m. Thank you.
It's my pleasure to move on to the next section. We'll be talking about C. diff, IBS, and diverticulitis, some gut-related problems that we encounter with some frequency. Before we get going, I just want to remind all the folks who are attending to please stay masked when you're not ingesting food or drink for everyone's protection, and maintain your social distancing. We'll try to keep this as safe as possible. Okay, well, let's begin with a discussion about C. diff. And it has that name, C. diff. The difficile is because it's difficult to culture. And when they were first seeing the organism, that was the concern about it. I have some disclosures to make, none of which are particularly important for this talk. So C. diff, as you're aware, is a bad problem for all of us. Antibiotic-associated diarrhea goes back to the start of use of antibiotics in the 1950s. There was an occasional problem that came up, sometimes was severe. There was an article that we published in ACG magazine about C. diff in the 50 and 25 year ago column. You can look at that to get some of the historical background on it. It was first linked to Clostridioides difficile as a problem after an epidemic of this occurred with use of clindamycin in the late 1960s and 1970s. And C. diff diarrhea accounts for about 15 to 25% of antibiotic diarrhea cases. Not everybody who has diarrhea after an antibiotic has C. diff. Many have other problems that relate to the changes in the flora that occurred, less efficient fermentation that allows osmotic diarrhea to become a problem. But we're going to be talking about C. diff today. It's a frequent problem. There are about 500,000 infections reported each year. And the big change that's occurred in recent years is there's more community associated infection. It's not all just a hospital problem. There's still a number of deaths from C. diff, which is unfortunate. It's not as lethal as coronavirus, but certainly many people with severe disease still go on to die from it. Particularly if you're old, that's a big marker for a bad course. Of course, everything's monetized these days, so $5 billion is a convenient number to keep in mind as excess costs, and it's the #1 healthcare-related infection in the US right now. So what's new about it? Well, the first thing is its name. You all grew up with it being Clostridioides difficile. Now it's been changed to a different genus, Clostridioides. And so you'll see that in more recent papers. It's one of those things that microbiologists do with some regularity every now and then. It's sort of like when Helicobacter changed from Campylobacter years ago. It's to keep us on our toes about things. So Clostridioides difficile is your old friend C. diff. We know more about risk factors, pathogenesis, host response, diagnosis, treatment, and the prevention of this. So we'll be talking about these different items. Well, the organism is a gram-positive rod. You can see a picture of it in stool here. It's all those nice blue rods that are there. And it's an obligate anaerobe. It can't tolerate any concentration of oxygen. It's a sporulating organism, which leads to its ability to spread widely in the human environment. The spores are resistant to heat, to acid, to oxygen, and to ethanol. They're killed by a 1 to 10 dilution of household bleach. So it's high-level disinfection that's needed to get rid of the spores. And you can see on this picture, the spores are all those little pink dots that are in between the blue rods. The organism produces problems with diarrhea because it produces toxins, and that's what mediates the disease. The organism is not particularly invasive. It lives in the lumen. It produces the toxin which damages the mucosa and causes secretion. If there's no toxin, if you have a strain that doesn't make toxin, or you don't have receptors for the toxin, like little babies don't have that developed yet, you don't get diarrhea from C. diff. Now, what are the risk factors for infection? Well, probably the number one dangerous feature is that you can be elderly or have some other cause for a weakened immune system. So again, that's a key feature. Healthcare settings are an easy area for it to spread around. If you think about it, with these spores that are resistant to most forms of cleaning, if you have a patient with C. diff in the hospital, you walk into the room, it's likely the spores are on the floor and you're tracking it around the hospital. When someone comes to take them down for an x-ray, the wheels of the litter get contaminated with spores. So these things get tracked throughout the hospital, and it's a very common place for people who are very ill, have weakened immune systems. If they are exposed to the spores, there's a good chance that they will get sick from them. The key feature is previous antibiotic treatment. Clindamycin, as I mentioned earlier, was a leading cause for this. It used to be called clindamycin-associated diarrhea at one time. But we know that virtually any antibiotic can cause this, even some of the ones that we use to treat C. diff. The risk increases with the cumulative dose of antibiotic that's given, longer durations of therapy, the number of antibiotics used. And the common theme here is that you're injuring the microbiota that normally exists in your colon and which resists colonization by C. diff just by taking up room in your colon. Of course, one of the biggest hazards is to have had C. diff before, because that means the spores were in your immediate environment. And they may still be in your house when you go back home, and you may reinfect yourself. So the risk factor for reinfection is having had C. diff before. Now, what's the pathogenesis of this? It's really pretty straightforward. We've learned a fair amount about the molecular biology of this, though, over the years. So item number one there, you basically eat the spores. They go down through your stomach. They're resistant to the acid in your stomach, so they can get down into your small intestine. And as you see in box number 2 there, the intestine is a site where they can be exposed to bile acid. And exposure to bile acid is important to allow the spores to germinate. So the small intestine, where the bile acid concentration is high after a meal, is a likely place for them to germinate. They go down to the colon and set up shop there. And in the colon, they multiply. It's a great environment for them. It's warm, it's dark, there's a low oxygen tension in the colon, so they can multiply very effectively. And there's a lot of food. When we eat, the leftovers of our digestion go down to the colon, and they provide fertilizer for the bacteria that live down there. So the C. diff multiplies down there. It will produce toxins that will affect the gut lining, and it also produces spores that then get pooped out into the environment. So this is a very efficient organism for causing mischief in people. And you can see in the little box there with the blown up enterocyte in it, that the C. diff has 3 different kinds of toxins. There's toxin A and toxin B that we're familiar with from the clinical lab. And these toxins cause disruption of the actin skeleton of the cell and cause weakening of the tight junction. So the cells become less adhesive, they fall off the mucosa, and you get the pseudomembranes, which is mainly the dead mucosal cells that we recognize endoscopically. There's also another toxin, CDT, which allows this C. diff to adhere better to the colon epithelial cells and magnifies the risk of the infection. So in essence, this is a chemical attack on the lining of the colon that causes it to be shed off. Now, how much toxin is made is the key factor that distinguishes different strains of C. diff. So for instance, there's what's now called ribotype 27, used to be NAP1 BI027, and it was responsible for an epidemic in Canada that was incredibly malignant for patients. There was a high case fatality rate, and it's because it produced 15 to 20 times more toxin than the average C. diff strain. So that causes a problem. There's another new virulent strain that's going around that you may encounter, ribotype 078. It affects younger patients, more outpatients, and for those who are incessant test takers, it's associated with proximity to pig farms. So if you see that in the stem of a question, they're aiming you towards a diagnosis of that particular strain. Strains that don't make the toxin don't cause disease. They're just passengers that are going through the gut. And so toxin is the marker that C. diff may be causing diarrhea. Now, one important feature to keep in mind is that the toxin is very labile and it must be assayed promptly. So if a patient is providing a sample from home, for instance, they need to keep it cool and get it to the lab quickly so it can be assayed promptly. If it sits around for a while, the toxin will be destroyed and you may get a false negative in that individual. As I mentioned earlier, immunocompromised people have more severe C. diff infections. So organ transplant patients, of which there are a number now, have problems. About 8.5% get C. diff in their first year after transplant. That's because they tend to hang out in hospitals where there's a lot of C. diff around. The median time to develop C. diff was a little less than 2 months, so this becomes a late complication of organ transplantation. But the thing to keep in mind is about 2/3 had a severe case of C. diff infection, and 28% went on to get recurrent episodes because they don't develop good immunity to the organism. This shouldn't surprise us. We have them on immunosuppression so they don't reject their new organs, and so that becomes a great problem. The risk of mortality after transplant is doubled if you have C. diff infection. C. diff in just cirrhotic patients, like we just heard about in the last session, nearly doubles the mortality rate. So if you have a cirrhotic patient in the hospital, they pick up C. diff, they're at great risk for dying. Recurrence rate of C. diff in immunocompromised patients is nearly twice that of immunocompetent patients. Again, they don't develop the immunity that you need to prevent reinfection. So who should we suspect for this? Well, obviously, anybody who's been on an antibiotic. And the thing to keep in mind is it can be up to a couple of months after the antibiotic is stopped that this may emerge. Less well known is the fact that anti-neoplastic agents may predispose people to C. diff. If you're living in an institutionalized setting in a hospital or nursing home, that can be a problem. But keep in mind that community-acquired cases are rising. And nowadays, almost half of the cases of C. diff are acquired at home and not in the hospital. Older patients are at special risk if patients have underlying disease, cancer, renal failure, generalized debility, things that make you less immune competent, they are at greater risk. And then people who've had modification to their GI tract, they may have had surgery of one sort or another, they may have tube feedings, be on enemas, be on PPIs or H2 receptor blockers. Those may all increase your risk of coming down with C. diff. Again, the onset can be delayed from weeks to months after the exposure to the antibiotic. In people who are hospitalized for at least 3 days, if they develop diarrhea in the hospital, C. diff is the most common enteric pathogen that's isolated. They don't have salmonella or shigella or things like that. Hospital kitchens are very good at killing any food they give the patients, so it's unlikely that they would acquire the usual enteric pathogens. If you have diarrhea, more than 3 loose bowel movements for 24 hours, with or without abdominal pain, and no obvious alternative diagnosis like laxative or drugs that cause diarrhea, then C. diff should be on your list of potential causes. Nausea, vomiting, and fever often are present, but not always. And physical findings can range from minimal to severe. And so you may have somebody who has no findings or somebody who has extreme tenderness. So what tests should we do to find if someone has C. diff? Well, there are 2 questions to ask. Is C. diff present in the stool? And is C. diff causing the disease? So the answer, whether it's present or not, you can do a culture and molecular typing. That's not done too often because it's a difficult and time-consuming process. You can do a nucleic acid amplification test, a PCR on the stool, to look for the organism. That's fast. You can get a result in a few hours with that. You can do an immunoassay for toxin A or toxin B or both. That'll detect the toxin that the organism produces. And you can do an assay for glutamate dehydrogenase on stool. Glutamate dehydrogenase is an enzyme that is almost unique to C. diff, but in the setting of someone with diarrhea, it identifies the fact that C. diff is likely to be present. So that lets you know if C. diff is in the stool. The question of whether it's causing the disease depends on showing that there's toxin present. Because if the organism is not making toxin, it's not causing their diarrhea. So the original way of doing this was to do a cell culture with cytotoxicity. So you'd grow a group of cells on a petri dish. You'd put that extract of the stool in the dish, and if the cells curled up and died, then that was evidence that toxin was present. That's not done very much anymore, except for research purposes, because it's difficult and it takes a little while, and you have to have cell cultures going all the time. What we do now is a toxigenic culture, where you grow out the organism and identify toxin in the supernate, or just a direct immunoassay on stool water for toxin A or B. That's the common thing that's done. So what are the limits of the test? Well, no single test is ideal for all comers. Tests vary in sensitivity and specificity depending on the cutoff that's used. And that's something that people don't always appreciate. If the cutoff is set high, you may still have a low level of something that may be causing a problem. And so, the usual rule of bell-shaped curves, about 5% of cases might not be detected just because of where the cutoff is set. The tests may be time-consuming or require special laboratory facilities. These are much more widely available than they used to be. And again, collecting the specimen may be suboptimal. If you're looking for toxin and the specimen's sitting at the nursing station for half a day before it's turned in, you may get a false negative result. So what are the current recommendations? Well, one is a multi-step algorithm. This is used in most hospital settings. They use the GDH assay as a screener, and then you see if the toxin is present or not. Now, the problem is that sometimes you get discordant results. You may have a positive GDH, but the toxin may be negative. And so what's done in that case is you need to do some sort of confirmatory test, and often that's a PCR type test. You can do the PCR and check for toxin directly. That used to be a little more expensive. Now that more of these multiplex assays are set up in more places, it's become a cheaper alternative. Now, in many places, they'll limit testing in the hospitals, but hospitals are incentivized not to diagnose C. diff infections because that counts as a bad mark for the hospital. It means they're not cleaning things up well enough. They get dinged for that by Medicare. So they have gone to somewhat extreme limits to not diagnose C. diff when you have someone with diarrhea developing in the hospital. So basically, they'll limit the testing to people who have more than 3 loose bowel movements for 24 hours, people who aren't on laxatives or drugs that might cause problems. And in that setup, we use tests like the nucleic acid test or the multi-step algorithm over just measuring the toxin. If the testing's not limited, then the multi-step algorithm is probably better than doing just the PCR test, the NAAT alone. Well, what about laxative use? In my hospital, if you have a patient who's been on a laxative and you send a stool down, they'll look in the chart and they won't test it if they've been taking a laxative. And the problem with this is that there are lots of people in the hospital who get laxatives because they're getting diagnostic tests or they're constipated, and they're not immune to getting C. diff. And excluding them from testing might delay the diagnosis. And this is something you have to keep in mind. There was one study done that's cited there which looked at hospitalized patients with new onset diarrhea, and they found over 200 patients who were positive on the PCR for C. diff, and 65 of them, a third of them, had taken laxatives just for being in the hospital. And it turned out that wouldn't be a bad thing if it turned out that laxatives were a marker for less severe disease, but there was no difference in the severity of the C. diff infection in those taking and not taking laxatives, and no differences in deaths, ICU admissions, and colectomy. So if your hospital's policy is not to test those specimens because they took a laxative, there are going to be some people who get severe C. diff who could have been diagnosed a little earlier. Now, what else can we do besides those tests on stool? Well, colonoscopy and sigmoidoscopy have been used since the original descriptions of this disease to show pseudomembranous colitis. But remember, that's not always present in patients with C. diff. Imaging studies like X-rays, CT scans, or MRI of the abdomen may show evidence of colitis, and that is somewhat confirmatory if it's present, but again, it's not always present. A really high white count of over 20,000, a high creatinine of over 2, a lactate of more than 5 are markers of really bad C. diff disease. And so those patients have an elevated 30-day mortality rate. So that should be taken seriously. Now, outpatients can get diarrhea from lots of different causes. And so you may need to do other testing for them. Recently, we've been promoting using the multiplex PCR assays for people with infectious diarrhea that's acute in order to sort out the organism quickly. The test results come back in 4 hours or so, so it's very helpful in terms of deciding about antibiotic therapy. But one of the tests is for C. diff. And if it's positive, then you need to do a toxin test to make sure that the toxin is present before you blame the diarrhea on the C. diff. What about treatment? Well, number one on the agenda is to correct fluid and electrolyte abnormalities. As always with diarrhea, that's the cause of death. Discontinuing existing antibiotic therapy, if you can, is a good idea. Some people used to advise, well, stop the antibiotic and then see what happens, because of the 3/4 of people with antibiotic diarrhea who get dysbiosis and get osmotic diarrhea from that. But if you know they have C. diff from your testing, it turns out that's not going to help very much. And maybe the mild disease will go away on its own, but the resolution rate's only 15% without antibiotic therapy. So that's probably not the best thing to do anymore. For most patients with C. diff infections, vancomycin or fidaxomicin should be used first line. And metronidazole, which used to be our first choice, shouldn't be used anymore because of resistance to that drug. It's second line therapy now. In late breaking news from the infectious disease meeting a couple of weeks ago, they're probably going to change their recommendations to use fidaxomicin first line and move vancomycin down to second line. And this is because of concern about deploying vancomycin for these infections and inducing resistance and other things like N-arcoxide. So you may see that recommendation come out when their committee finishes its work, which will be a major change in how we deal with this. Now, for mild disease, you can use a relatively low dose of vancomycin or fidaxomicin. If you have severe or fulminant disease, you need to use a bigger dose. And if someone has a dysfunctional GI tract, you need to get the vancomycin inside the GI tract for this organism. It's not an invasive organism. The antibiotic to kill it has to be in the lumen. So if they can't just take the capsules or the preparation that the pharmacy gives you for oral use, you need to run it down an NG tube or potentially even give enemas with vancomycin. It's also recommended in those people who are having dysfunctional GI tracts that they get intravenous metronidazole at the same time. And you probably, for severe disease, should get a surgeon on board so they're familiar with the patient, because these folks can go bad quickly and they'll need a colectomy. That's still done from time to time. And remember, there's still nearly 30,000 deaths a year from this. So it's something that is not just theoretical. How about C. diff that complicates IBD? This is something that we recognize more. Dr. Frey, who will be giving a talk tomorrow, may talk a little bit about this in his talk. But C. diff can complicate the course of both ulcerative colitis and Crohn's disease. In part, this is because we sometimes give these people antibiotics for other things, but also just because they have impaired immunity from some of the medicines we give can be a big issue. And recurrence is common in this group. So generally, if you have someone with IBD who gets C. diff, you need to consider a longer duration of therapy, and that will lower the recurrence rate. If you look at the numbers there, the short duration of therapy, it's about 12%. You could reduce that to about 2% if you give more than just the usual 10 days or so of therapy. Now, fidaxomicin, I mentioned earlier, may be moved up to the #1 drug for this soon. It was non-inferior to vancomycin in the study they did. It was not powered to show that it was better. But even in that study, there seemed to be a lower recurrence rate. And so that's one of the things that is pushing the Infectious Disease Society to change their recommendation. There are a bunch of alternate antibiotics that people have talked about, but there's very limited information about any of these. And there's an inconsistent response using adjunctive resin to bind the toxin or to bind bile acid and interfere with the pathogenesis of the disease. So you see some people using cholestyramine or cholestyramine to try and quit recurrences. It may work, but there's not good data on it. Probiotics may reduce the recurrence rate, but it's not a generalizable thing. It's only Saccharomyces boulardii, and it's limited data from one study. So this is not something that's a sure thing to reduce reinfection. If someone does get relapse, then you need to use a better drug. If they were on metronidazole initially, then give them a course of vancomycin. If they had vancomycin originally, then you may want to try a tapered pulse dose regimen that takes a couple of months to get people off the vancomycin. You reduce it very gradually. Or you can try a 10-day course of fidaxomicin and see if that works better. For subsequent relapses, again, the tapered pulse dose vancomycin is probably what's used most often. Sometimes rifaximin or fidaxomicin is used as a chaser after that long course. And then, of course, the big gun we have is fecal microbial transplantation, stool transplant, and it's recommended for people who've had 2 prior recurrences. Now, this is used for people who've had resistance to antibiotic therapies or if they have multiple recurrences. You need to stop the antibiotic for the C. diff at least a day or 2 before you do the transplant. And the thing is not to restart them after the transplant. The transplant itself should do the job. Success rates more than 80% in most studies. Some of the early reports had it over 90%. And cure rates are lower in controlled trials and in open label studies, as you might expect. The relapse rate is clearly lower than standard antibiotic therapy, and that's its main feature. And using that right off the bat is still being explored. So it's not recommended to use on the first go around with C. diff at this time. So why do people relapse? Well, most of the time we think it's reinfection due to residual spores after antibiotics suppress the vegetative cells. It may be ingestion of new spores from the environment. There hasn't been great studies to look at that. In most patients, we think an inadequate immune response plays a role. So the reason for that is that if people get higher titers of antibodies to toxin B, but interestingly not toxin A, they have a lower frequency of recurrence. But antibodies by themselves are not completely protective. They are helpful though. In fact, a drug has been developed, bezlotoxumab, which is a monoclonal antibody against toxin B. And the idea with this is you give it intravenously to provide passive immunity to the toxin. You still have to give the oral antibiotic to kill the organism off. But if you give this as an additional infusion, it reduces the recurrence rate by approximately half. And so that's something to think about in people who remain at risk for getting reinfection. All those people who are older, who have had prior history of C. diff, who have compromised immunity or had a bad strain of C. diff in their past. So this is something to keep in mind as an adjunct to your therapy for C. diff to prevent recurrence. Future developments, there are some new antibiotics that are being developed, some more successfully than others, and we'll just have to see if any of these make it over the finish line. Another approach that people have been taking is to try and manipulate the microbiota, since people think that antibiotic depletion of microbiota in the colon is a key thing. One of the products, the SIR 109, is a bunch of spores from different firmicutes, and It's from healthy people. It's sort of like a standardized stool transplant in a way, but just with one group of organisms. And studies are being looked at right now. You can give C. diff strains that don't make the toxin, and that may reduce the recurrence. You basically are putting a ineffective C. diff organism in the gut. And then the idea of standardizing fecal microbial transplant, and there are several products. The difficulty with FMT right now is we're in the midst of this COVID epidemic. No one wants to get germs from somebody else. And it's very likely, since COVID's been shown in stool, that you could get it from a stool transplant. So, for instance, OpenBiome, which many of us have used as a commercial source for a stool rather than making it yourself, was shut down basically by the FDA until they could screen everybody for COVID. So they're going through their stool library and trying to strain that out. And I think it's going to come back online soon, but I haven't gotten a final word on that. The most interesting one from my point of view is bacteriophage therapy. And bacteriophages are viruses that infect bacteria. And they're very specific in which bacteria they'll kill. And so if you gave a bacteriophage that would kill C. diff, you get rid of this. And so that certainly makes some sense. It may be why FMT works. I mean, why should, giving a small amount of feces into a big colon get people better in half a day? That doesn't make a whole lot of sense. But if you're giving a bacteriophage in that mixture, not a bacteria, but a virus that's killing the C. diff, that might be a mechanism for at least some of them. So there's some ways people are looking at getting these phages in the colon. The big hope is immunization, and it should be feasible. This is a toxin. It's just like tetanus toxin. And all of you have had tetanus toxoid, so you don't get tetanus when you step on a rusty nail. Well, there's no reason in my mind why you couldn't do the same thing for this toxin. And there's been some work along those lines, but it's been agonizingly slow. I mean, this is not a new idea. And it's been a very slow process to get this out there. But eventually, this may be how we get rid of this as a human pathogen. So summary, takeaway points. It's now Clostridioides difficile, and it remains a big challenge in the hospital and increasingly in the clinic. The disease is toxin-driven. There's a potential for immunization because of that. The diagnosis is best achieved by multiple strategies. The treatment's moved away from metronidazole and toward vancomycin or fidaxomicin. Relapse of this is problematic and frequent, and new strategies for dealing with this are emerging. And prevention is the key for now. So you want to have good antibiotic stewardship. People shouldn't be getting antibiotics for ordinary kinds of watery diarrhea that they get. Hygiene in the environment is also very important. And this is something that we're doing for other reasons now. And it'll be very interesting to see if all the attention to hygiene in the hospital results in less C. diff in the hospital. I think it's very likely that that will actually happen. Just as in Australia this last summer, the incidence of flu is way down from usual because everyone's running around with masks on. So we'll have to see what happens in the future, but this continues to be a rapidly evolving area of medicine. There's a bunch of interesting recent articles that you can look at your leisure about this. Good luck in treating your patients with C. diff in the future. All right, well, thank you very much. Anyway, we'll now move on with our next talk, and I'm very happy to introduce Dr. Bill Chey to you, the man who needs no introduction. You probably have heard him before and know what a great lecturer he is. He's going to talk to us today about microbiome-based treatments for IBS, food, bugs, or drugs. So Bill is in Michigan, and hopefully you'll see him here in a second.
Hello, everyone. My name is Chey. I'm a professor of gastroenterology and nutrition sciences at the University of Michigan in Ann Arbor. And I'm going to talk to you today about microbiome-based treatments for the irritable bowel syndrome, or IBS, bugs or drugs. This is my disclosure slide. And I think it's valuable to start off with a discussion of definitions, microbiota versus microbiome. The microbiota refers to the overall community of microorganisms living within your GI tract. The microbiome, on the other hand, refers to the collective genomes of those microorganisms. So microbiota, organisms, microbiome, the genomes. Now, the microbiota and microbiome have a profound influence on normal development and function of the gastrointestinal tract. It plays a role in immune activation, permeability, secretory function, visceral sensation, as well as motility. So the microbiome is critically important to the health and development of disease in regards to gastrointestinal disorders. There are a plethora of different factors that can influence the composition of one's microbiota. How you're born. For example, vaginal delivery and cesarean section leads to different characteristics of the microbiome. Genetics, your environment, i.e. your diet and how clean of an environment you live in. Your level of physical activity, psychological distress, medications, as well as whether you smoke or drink, all these things can influence your microbiota. An age-old question has been, is there greater influence on the microbiome from genetics or environment? And we got at least a partial answer to that by a very important paper that was published in Nature now more than a year ago, which actually came to the realization that environment plays a significantly greater role in shaping the microbiome than does genetics. And they did this by looking at the microbiome from individuals who were very similar genetically, i.e. twins, who were living apart, versus those individuals that were not genetically similar, but living together. And what they found was that the people that had very different genetics, but were living together, actually had more similarity in their microbiome than people that were genetically very similar, twins living apart. We're going to focus the rest of our discussion on the irritable bowel syndrome, or IBS. And remember that IBS, according to the Rome 4 criteria, is a symptom-based diagnosis relying upon the presence of recurrent bouts of abdominal pain in association with altered bowel habits. And that altered bowel habits can be either diarrhea, constipation, or a mixture of diarrhea and constipation. The current thought in regards to the pathophysiology of IBS is that it's heterogeneous. There are probably multiple factors which interplay to different degrees in individuals leading to the symptoms of IBS, abdominal pain and altered bowel habits. It's becoming increasingly clear that what's happening in the luminal environment, the luminal microenvironment of the GI tract, is critically important in regards to influencing the function of the enteric nervous system, which communicates with the brain in our heads, as well as the gut immune system. And it does so via the epithelial cells that line the gastrointestinal tract. So although we've made fun of for years of patients talking about leaky gut, it turns out that intestinal permeability likely does play a critically important role in terms of separating what's going on in the luminal microenvironment from those nerves and immune cells in the wall of the intestine and colon. We also know that there are intrinsic differences in the microbiome between patients with IBS versus healthy controls. In fact, a recent meta-analysis published in Gastroenterology actually amalgamated data from 24 studies conducted in 22 different manuscripts published in the medical literature. And they found that while there were differences from study to study, a consistent message was that the microbiome from patients with IBS differed from healthy controls. Some of the more durable themes, recognizing that none of these things are universal themes, but some of the more durable themes were that IBS patients had lower concentrations of bifidobacterium and fecal bacterium and higher concentrations of lactobacilliaceae Bacteroides, and Enterobacteriaceae. We also know that there are a number of lines of observation and science that link the microbiome or microbiota to IBS. First is this concept of post-infection irritable bowel syndrome, this notion that while the vast majority of people that experience an acute gastroenteritis, traveler's diarrhea, food poisoning, completely recover with no consequences, there's a small percentage, maybe on the order of 7 to 15%, who will go on to develop more long-lasting symptoms compatible with the diagnosis of IBS. And that's what we refer to now as post-infection IBS. By the way, the correct terminology is post-infection IBS, not post-infectious IBS. Also, we know that children exposed to multiple courses of antibiotics are more likely to go on to develop irritable bowel syndrome later in life than kids that don't receive antibiotics. And finally, we also know that a whole range of microbiome-based therapies, whether you're talking about diet, probiotics, antibiotics, can offer benefits to subsets of patients with IBS. Again, drawing that possibility that manipulating the microbiota may in some way impart benefit to at least a subset of IBS patients. We're going to next turn our attention and really spend the rest of our time focusing on treatment options that involve the microbiome in patients with IBS. And I like to use a garden motif as I think about the different options that can affect the microbiome. First is fertilizer, so prebiotics in food. Then there's seed, so thinking about probiotics and fecal microbial transplant in that category. And then finally, weed killer, and that would be antibiotics. And you need all of those different things in different proportions to really get the most beautiful garden, as depicted at a picture of Mathai Gardens from the University of Michigan. So let's start off with diet. And we're going to talk about a variety of these different interventions, but we're going to start with diet. People may not necessarily think about diet as a microbiome-based strategy, but it is, and I'll show you data for that in a second. But realize that right now, the most evidence-based diet therapy for patients with IBS is the low FODMAP diet. There are actually multiple randomized controlled trials. We summarized data from 7 randomized controlled trials in this meta-analysis that we recently published in the Red Journal, which showed that in aggregate, the low FODMAP diet was more likely than a number of different comparators to provide benefit to overall symptoms in patients with IBS. Now, in fairness, you'd have to say that there was significant heterogeneity from trial to trial, a whole bunch of different comparators. These studies were not blinded, different durations, different numbers, all relatively small numbers of patients. So bottom line here is there was a high risk of bias. So this is by no means a perfect data set, but the data that we have fairly consistently suggests benefit for a subset of patients with IBS. Now, right now, we're still in an era where we empirically choose a diet or a medication, for that matter, based on a patient's symptoms. But really where we want to go is more towards a precision medicine, or in this case, a precision nutrition model. Precision nutrition is defined as it suggests that it's possible to have sufficient quantitative understanding about the complex relationships between an individual, his or her food consumption, and his or her clinical phenotype, including health, to offer nutritional intervention or advice, which is known to be individually beneficial. So how close are we at the current time to a precision nutrition model? Well, we're still a long ways away, but we do have some glimmers that suggest that we might be able to develop strategies or biomarkers that would allow us to go down this precision nutrition pathway. For example, there are now multiple studies, 3, 4, 5 studies, showing that characteristics of the microbiome, the stool microbiome, before a person goes on a diet intervention can predict whether they're likely or not likely to respond to a dietary intervention like the low FODMAP diet. This is data from Norway showing just that characteristics of a patient's stool microbiome before they go on diet intervention, identifies patients who are more likely to respond to the low FODMAP diet. There's also data suggesting that metabolomics, in other words, looking at the metabolic byproducts that are arising from the activity of the microbiota in the GI tract, can also offer insights into whether a patient is less or more likely to respond to the low FODMAP diet, or for that matter, in this case, as this study shows, also a probiotic supplement. So in this study, investigators from King's College actually looked at volatile organic compound profiles from gases emitted from stool collected from IBS patients before they were either treated with a low FODMAP diet or a probiotic supplement. And this is what they found. They actually found that characteristics of the VOC patterns almost perfectly predicted the patients who were responders to the low FODMAP diet or a probiotic supplement. I mention that because this strategy may, if it turns out that this is validated by other groups, may be applicable broadly to microbiome-based strategies. Let's next talk about pre-probiotics and postbiotics. So realize there are many studies which have evaluated the potential benefits of probiotic supplements in patients with IBS. In fact, in this systematic review meta-analysis that was part of the American College of Gastroenterology evidence-based monograph on treatment of IBS, they identified 53 randomized controlled trials with over 5,500 patients enrolled in these trials. And overall, there was a small but statistically significant benefit offered by probiotics in terms of improving global IBS symptoms, abdominal pain, bloating, and flatulence scores. Unfortunately, what was also found, though, was that the evidence was not strong enough to be able to make specific recommendations regarding specific probiotic supplements. So while this document said we suggest probiotics taken as a group to improve global symptoms, as well as bloating and flatulence in IBS patients, it also was very clear to say that they could not recommend, that we could not recommend specific probiotic supplements for patients with IBS. And the AGA, in their document that was just recently published, actually went a step further and said that probiotics should only be used in IBS patients as part of a clinical trial. That right now, the evidence really does not match the enthusiasm that patients have for probiotics as a treatment of IBS. Also realize that probiotics may offer benefits for cognitive emotional function. So-called psychobiotics have been evaluated now in a wide range of different trials in healthy volunteers. And in this meta-analysis that was just recently published, it was actually found that psychobiotics were more likely than placebo to lead to improvements in depression, anxiety, and stress in otherwise healthy individuals. And we now also have a study from IBS patients that suggests that a psychobiotic, Bifidobacterium longum, NCC 3001, was more likely than placebo to lead to improvements in mild depression in IBS patients. And that was associated with measurable changes in the amygdala and other parts of the brain involved with cognitive emotional function measured by functional MRI scanning. However, there are a number of points to ponder. Again, the ACG, evidence-based treatment monograph, and the AGA guidance on probiotics have both been pretty conservative in terms of recommending the use of probiotics in patients with IBS. And I must say that I agree with those recommendations. Realize that the current quality of evidence is really low. That the empiric therapy paradigm, this idea that one size fits all, you give this probiotic to all the patients with this symptom-based condition, probably doesn't even make a lot of sense based upon all that I've told you in regards to the heterogeneity around the microbiota and the metabolome that occurs as a consequence of the microbiota. Also, remember that probiotics are regulated as food supplements. So bottom line here, buyer beware. Switching gears a little bit, but on the same theme, realize that there's growing interest in providing prebiotics instead of probiotics as a treatment for IBS. So this is one study that was recently published by a group in Spain that looked at the low FODMAP diet versus a prebiotic and a modified Mediterranean diet in a relatively small number of IBS patients, and found that while both improved symptoms compared to baseline, there was no difference in the magnitude of benefit between the two interventions. Now, the paper concluded that this was a consequence of the prebiotic supplement, but another question that one might ask is whether or not the Mediterranean diet offers potential benefit for patients with IBS. Time will tell. We need more data on that particular point. All right, let's next shift focus to antibiotics. And just review the data suggesting that rifaximin provides benefits for global improvement in IBS symptoms. This is data from a meta-analysis we published a number of years ago now. At that time, even in 2012, there were 5 randomized controlled trials, all suggesting benefits for global IBS symptoms in patients using rifaximin versus placebo. The Target 3 study is the most recent randomized controlled trial, a very large study, over 2,400 patients who all received an open label course of rifaximin. And by the way, the response rate was 44%, exactly the same as the response rate that we reported in that meta-analysis I told you about a moment ago. Of those individuals that responded, about 2/3, or roughly 60%, experienced a recurrence in their symptoms during the follow-up period. And those patients were re-randomized to either a second and third course of rifaximin or placebo. And bottom line here is that the second and third courses of rifaximin, again, led to small but statistically significant benefits in terms of improving overall IBS symptoms compared to placebo. And that's why the current FDA approval is for 550 milligrams 3 times a day for 14 days, up to 3 courses of therapy. Now, a really important question here, and particularly in light of the response to rifaximin, is whether patients that get better from rifaximin are suffering from SIBO or whether they're suffering from IBS. In other words, it may very well be that SIBO simply leads to symptoms that otherwise look just like IBS, but it might also be that patients with IBS related to their underlying abnormalities in motor function, immune function, permeability, might be predisposed to developing SIBO. So what's the chicken and what's the egg still remains to be determined. What I think is pretty irrefutable at this point, though, is the relationship between bacterial contamination of the small bowel and a higher likelihood of patients reporting IBS symptoms. This is a meta-analysis by Eric Shaw, who actually amalgamated data from a number of clinical trials, mostly case control studies, that very clearly shows an increased likelihood, a 10-fold increased likelihood of a positive breath test in IBS patients compared to non-IBS patients. Now, at the current time, not unlike diet therapy, as we mentioned a moment ago, we're really practicing an empiric style of medicine. In other words, if a patient has IBS-D symptoms, we think about treating them with rifaximin. But given this potential relationship with small intestinal bacterial overgrowth, is there a way to leverage that might identify patients more likely to respond to rifaximin? And the preliminary evidence from studies so far is yes, that is probably true. There is data from a study looking at small bowel aspiration and from breath testing, both of which show that individuals with evidence of bacterial contamination of the small bowel by quantitative culture or by breath testing are significantly more likely to respond to rifaximin. So it may very well be that as time goes on, we evolve our thinking to employ biomarkers like breath testing, for example, to identify the patients who are most likely to respond to a course of rifaximin. All right, let's finish up by talking about fecal microbial transplant, and just mention that there's actually quite a few studies evaluating FMT in patients with IBS. A recent meta-analysis published in Elementary Pharmacology and Therapeutics summarized data from 5 randomized controlled trials. And I think a subgroup analysis from this meta-analysis is very interesting because it suggested that there may be differences in response based upon the way that the FMT is administered. So capsules appear not to work at all in the studies that are currently available. On the other hand, colonoscopy and nasojejunal tubes may provide a better response. Now, it's important to mention that at the current time, when you look at all the data together from those 5 randomized controlled trials, there is no statistically significant benefit offered by FMT compared to sham FMT. But again, there are a lot of details to be worked out that may allow us to identify the right way to administer the fecal microbial transplant and the right patients that might benefit from a fecal microbial transplant. So to summarize, treatments that affect the microbiome improve symptoms in a subset of IBS patients, and this extends to possibly probiotics and prebiotics, although right now the data is pretty shaky for both those. Antibiotics, no question that makes a significantly greater subgroup of individuals with IBS better. Diet, right now, the most evidence-based is the low FODMAP diet. FMT, again, very experimental right now, certainly should not be considered a standard treatment for patients with IBS. The microbiome and metabolome might be leveraged to create biomarkers, which could assist in the diagnosis and treatment selection of IBS patients. So with that, I'm going to conclude and thank you for your attention. I hope you enjoy the rest of the meeting.
Okay, well, thank you very much, and good afternoon, everyone. It's my pleasure to be with you today, coming from Cedars-Sinai Medical Center in Los Angeles. I am the Director of Health Services Research at Cedars and the co-editor-in-chief of the American Journal of Gastroenterology. And today I'll be speaking with you about the spectrum of diverticular disease, an evidence-based update. Of course, diverticulosis is a very common condition, but one we don't necessarily talk a lot about, almost because it's so common, we feel like we know enough about it. But what I'm hoping to do today is to emphasize there's a lot more to know about diverticular disease. Now, just by way of disclosures, here is information regarding research support and other potential conflicts, none of which are directly related to the material that I will be presenting today. So we see this a lot in gastroenterology very, very often. When we do colonoscopy, we'll come across these diverticula, and people have questions about these. And here is a study that looks at the most common findings in people undergoing routine colonoscopy. And you'll notice, which is pretty amazing, is diverticulosis in both men and women is the single most common finding in a routine screening colonoscopy. It's even more prevalent than finding hemorrhoids, finding a polyp, or even finding a normal examination. So obviously we see diverticulosis a lot. It goes into the report. And when it goes into the report, naturally people are going to have questions about that report. They want to know, what does this mean for me? Should I change my diet? I've looked on the internet and I see that these can cause infection and can cause pain. What is the chance that this is going to go on and cause an infection? And we need to have answers to these questions as gastroenterologists. So for example, I want to start with this very common and important question. If we find diverticulosis in a screening colonoscopy, and somebody goes online and wants to know, does that mean I'm going to get diverticulitis? What are the chances of a real complication? Naturally, most commonly diverticulitis. So I want to address that question first. And so there is a traditional teaching on this. These are the ACG guidelines on diverticular disease. And to date, these are still the most recent guidelines, which is amazing because it's from 1999. This is 21 years ago now. The American Gastroenterological Association has more recent guidelines, which I will address, but I want to just start here with these ACG guidelines. And if you read these guidelines and you look at the text in the guidelines, they emphasize that diverticulitis affects 10 to 25% of people with colonic diverticula. So if I'm a patient and I was just diagnosed with diverticulosis on a screening colonoscopy, I might get kind of concerned because there's a up to 1 in 4 chance that this is going to go on and develop diverticulitis. Well, is that true? Is it really that high? There is a reference there, reference number 3. So I decided to look up reference number 3, and it's a study from 1975. 1975, we weren't doing routine screening colonoscopy. So how do we really know what the prevalence of diverticulosis was? So I decided to go look at that study, the PARC study, and it turned out that we had to go to the stacks of a library to find it. And in that study, they refer to other research going back to 1937. So how do we know that this is an effective reference to use in our guidelines? And if you look at other guidelines from surgical societies, they also refer to this PARC study. So, it's always worthwhile to ask, where does this data point or this guidance come from? And is it really the case that we can rely on studies from the mid-century, from right after World War II, to make decisions in 2020? I think we can do better than that, and better than 1937, for example. So in 2013, I and my team used data from the VA and looked at this question of what is the long-term risk of acute diverticulitis among patients with incidental diverticulosis found during colonoscopy. And in this study, what we did is we followed people who underwent a routine screening colonoscopy and looked to see if they progressed over time to developing diverticulitis. So we had over 2,000 people in this study who were found to have diverticulosis, and there was only a very small subgroup of only 95 subjects that went on to develop diverticulitis. That was 6 per 1,000 patient years. Now that was, we just required a doctor to write in the chart that it was diverticulitis, but sometimes diverticulitis is incorrectly diagnosed. So we also looked at a more rigorous diagnosis where patients had to have evidence on CT scan or surgical specimen of clearly having diverticulitis. And when we looked at it that way, the incidence was 1.5 per 1,000 patient years. The median time to event was 7 years on average. So it's actually a very low absolute risk of developing diverticulitis over time. Now, what we did find that was very important is the incidence changed according to the age of the patient. So people who are in their 70s have a lower event rate compared to those in their 40s. And that's very interesting. It's not just that people in their 40s have longer to live, it's actually per unit time. There is a faster onset of diverticulitis compared to those found with diverticulosis at an older age. And this suggests that there may be biological differences in diverticulosis based upon the age of the patient. And that's something worth understanding more about. Now, I want to emphasize some of the findings from the AGA guidelines, which are more recent. These are 5-year-old guidelines now. And just address a few really important clinical pearls for gastroenterologists. And so it says in here, the AGA suggests that antibiotics should be used selectively rather than routinely in patients with acute uncomplicated diverticulitis. That is quite different from what we generally practice and what we learned, which is that when somebody does develop diverticulitis, we should use antibiotics for it. And this is based upon or at least this new guidance to be selective is based upon two recent randomized trials and systematic reviews that report no clear benefit and actually question the routine use of antibiotics. So I would only say that it's up to you clinically to determine, and generally speaking, this is not our decision. It's the surgeons or the primary care physicians making this decision, but they may ask you about it, and it's worthwhile to be aware that the guidelines now actually say that it is selective. You don't have to use antibiotics, particularly in uncomplicated acute diverticulitis, but that's ultimately up to you to decide. No clear benefit. Now, we also, in the American Journal of Gastroenterology, published this study, which looked at long-term effects of omitting antibiotics. The original study looked at short-term effects, but this follow-up study looked at long-term effects and really did not find any more, a higher incidence of complicated diverticulitis or recurrent diverticulitis at long-term follow-up. So this is another study that suggests we don't necessarily need to use antibiotics in everybody with acute diverticulitis. Another question that frequently comes up, although our surgical colleagues make this decision, but we still should be aware of it because we often receive questions about this, is when to perform surgery. And elective surgery for acute diverticulitis has historically been a little bit of a crapshoot, so to speak. It's, in other words, unclear really when to do it. The decision, according to these 2014 guidelines from the American Society of Colon and Rectal Surgeons, the decision to recommend elective colectomy after recovery from uncomplicated acute diverticulitis should be individualized. Okay, well, that's not terribly helpful, other than we don't really know. It used to be, well, if they have diabetes and they've had, you know, two cases, then you should take it out, or it depends on how old they are, it depends on this and that. Most of those rules are not really evidence-based. In fact, in the guidelines, they emphasize that despite previous emphasis on the number of attacks dictating the need for surgery, the literature demonstrates that patients with more than 2 episodes are not at an increased risk of morbidity and mortality compared to patients who have had fewer episodes, signifying that diverticulitis is not necessarily a progressive disease. And there's more text there that I won't read right now, but you can take a look at, which is taken from this. So this is important to know. We are still waiting for really good randomized controlled trials to help answer this question of when really should we recommend surgery. The University of Washington has an NIH grant right now that's going to help answer that question. And we look forward to hearing more about that as the data come out. Now, another question that's worth knowing about is, let's say somebody has acute diverticulitis, they have now recovered from it, didn't get surgery though, and the question is, do we need to do a follow-up colonoscopy? The AGA suggests, indeed, that colonoscopy should be performed after resolution of acute diverticulitis in appropriate candidates. And they highlight, and some of the text on the right, which I won't read for you, but you can read on your own when you'd like, is basically the data do indicate that there is a slightly increased risk of underlying malignancy or advanced adenomas in people who have had acute diverticulitis. And, you know, just doing a CT and not seeing a mass lesion does not rule out the potential for underlying neoplasm. So generally they recommend about 6 to 8 weeks after resolution of acute diverticulitis is a time to consider doing a follow-up screening colonoscopy. Okay, so far I've been talking about diverticulosis, and I've been talking about acute diverticulitis and the progression from one to the other. But for the rest of my talk, I want to take a step back and think more broadly about the spectrum of diverticular disease. And this is a figure from a paper that I published about 8 years ago that I'll show you at the end, which is sort of a review of the spectrum of diverticular disease. And so the way we think about it is you either have disease or you have asymptomatic diverticulosis. And under disease, we can think about diverticulitis, which is a condition where you can see evidence of inflammation, either on CT scan, on surgical pathology, on colonoscopy. There's erythema, there may be other complications. Or you may have symptomatic, uncomplicated diverticular disease. So here, it's symptomatic, but you don't actually see any macroscopic evidence of inflammation or damage, but yet they continue to have IBS-like symptoms. And I'm going to talk a lot about SUD in a bit. Under the more traditional diverticulitis, it can be acute, like we've been talking about, or it could be chronic. Chronic can be either chronic recurrent diverticulitis, a sort of recurrent fulminating sort of form of diverticulitis, or you can have segmental colitis associated with diverticulosis or SCAD. So I want to talk about SCAD and I want to talk about SUD now that I've talked a little bit about acute diverticulitis. So let's just briefly talk about SCAD. This is a condition some of you may have seen before or may not have known what you were looking at and thought it was inflammatory bowel disease. SCAD is sort of a form first or an early form of IBD, but it is a distinct disorder. It's more common in older adults and in men. And typically what you see here is you're doing a colonoscopy and you see this inflammation, typically in the sigmoid colon, in and around diverticulosis. And I mean, there's a patch of diverticula, and you see a lot of inflammation, not just around the mouths of the diverticula, but all around the segment of colon. And it looks like IBD. Now, characteristically, unlike IBD, it will spare the rectum. Now, on histology, when you see this, you may see things that look like IBD. There's granulomas, architectural distortion, and Paneth metaplasia, changes that make you think, wow, this looks like IBD. But you'll notice it's only in the segment of diverticulosis. So we don't exactly know what causes it. It may be that in the genetically susceptible host who has bacteria harbored in diverticula, that it triggers a local immune response that leads to an IBD-like picture. And the fact is that it often can resolve spontaneously, or in some cases will respond to 5-ASA mesalamine, which again makes it seem like this is an IBD-type picture. But it's usually self-limited. And if it's not, and or it progresses, then you have to think that this might actually be IBD. So that's my only slide on SCAD. This could be a talk unto itself, but I wouldn't be complete if I didn't mention SCAD as an important disorder. Now, for the rest of this talk, I want to talk about SUD, or symptomatic uncomplicated diverticular disease, because it is a very big deal, and it can look and feel an awful lot like IBS. It might even be IBS, but with the presence of tics. There's very similar symptom profiles: recurrent abdominal pain, discomfort, bloating, diarrhea, and they often will overlap in cross-sectional studies, meaning people with tics have a higher prevalence of IBS-like symptoms compared to people without diverticulosis. And in people who have examined these patients with IBS-like symptoms and diverticula, and they look at it, they do find overlapping pathophysiologic mechanisms. Chronic low-grade inflammation has been found on biopsies in and around the tics in these patients. Alterations in gut microbiota, visceral hypersensitivity, abnormal colonic motility. This is like a best, a greatest hits for the mechanisms of IBS, and it's also listed as mechanisms of SUD. So maybe these are kind of the same condition. This is an area that is under investigation. So I do want to talk about the study of looking at diverticulosis and symptoms and colonic inflammation. This was a population-based colonoscopic study published in 2019, and they found that people with the tics are more likely to have abdominal pain, diarrhea, and mushy stool, and not statistically significant, but bordering on it, more lymphoid aggregates, which may or may not be important. And this is an example of one of the lymphoid aggregates that was described on biopsying these patients with IBS-like symptoms. Don't know the importance of that. But diverticulosis was not associated with increased CRP levels or other inflammatory markers: cryptitis, apoptosis, Paneth metaplasia, crypt distortion, and so on. Now, this is another study where they actually found colonic diverticula were not associated with mucosal inflammation or symptoms. So the story is not one-sided. It's still evolving just how commonly tics really cause symptoms. Another question that comes up is, can diverticulitis cause IBS? By that I mean, just like we have post-infectious IBS, where somebody gets traveler's diarrhea and then they recover, they clear the organism, but they have persistent IBS-like symptoms for months or years later. Is there a post-inflammatory IBS, or after an acute diverticulitis, people can get irritable bowel syndrome? Well, this is a study that we conducted several years ago entitled Increased Risk for IBS After Acute Diverticulitis. And in this study, what we did is we took people who had acute diverticulitis, and they did not have IBS symptoms prior to their diagnosis. And we then monitored over time to see if they collected or acquired a new diagnosis of IBS. And then we compared them to a control group who was age and sex matched control, who came to the hospital for some other reason on the same day, but not for diverticulitis. And then when we looked at the incidence of new IBS diagnoses, we found about almost a 5-fold increased incidence, or in this case, a cumulative hazard of IBS compared to control, suggesting that maybe there is a post-diverticulitis IBS-like picture. We looked at another way, and we looked at it another way, looking at not just IBS, but any functional GI disorder. And once again, we saw separation where the people with diverticulitis had about a 2.5-fold increased risk of developing any functional GI disorder, like functional dyspepsia, functional abdominal pain. And then we did a third analysis where we looked at not functional GI disorders, but the incidence of depression. And this is important because we know comorbid depression and anxiety are common in IBS and functional GI disorders. We wanted to see, is there a difference in the incidence of depression after diverticulitis compared to controls? And why would people who came to the hospital for another reason be any different in terms of the risk of depression? Well, once again, we found this separation of about 2-fold increased risk of depression in age and sex match compared to age and sex matched controls. So this sort of suggests that there may be a story evolving that there is a post-infectious, or rather post-inflammatory type of functional GI disorder. And I've talked about some of the potential mechanisms. So the question now is, how can we treat these patients? And maybe we can modify low-grade inflammation with 5-ASAs. That works for SCAD. Does it work for SUD? What if we use antibiotics or probiotics? Does that help? What if we do something like fiber to help with colonic motility, or centrally acting agents for visceral hypersensitivity? What is the evidence that these work for symptomatic diverticulosis or SUD? Well, what about 5-ASAs? This is a study that is a randomized controlled trial from Neil Stolman and colleagues that in the end was a negative study, maybe slight separations here and there, but did not show benefits of using mesalamine. This is another study that, once again, did not show benefits of using mesalamine. And I won't break down every little bar here. You can look at it, but the bottom line is these are negative. You can see the p-value. If anything, there was a slight trend in favor of placebo. And when we look at this from a meta-analysis point of view, mesalamine does not help prevent either recurrent acute colonic diverticulitis or even reduce symptoms of symptomatic diverticulosis. So unfortunately, it does not look like 5-ASAs, which are generally very safe and effective in IBD, certainly UC, it does not seem that they can reduce the new onset of diverticulitis or reduce the symptoms. So the 5-ASA literature has sort of not panned out, unfortunately. What about if we use antibiotics? So this is, these are meta-analyses from 2011 looking at the use of rifaximin in particular, a gut-specific poorly absorbed antibiotic that's often used in irritable bowel syndrome. Here looking at the risk reduction for symptoms and looking at it for prophylaxis on the right for acute diverticulitis. And what's really marked or striking is on the left, the number needed to treat is only 3. So that's a very low number needed to treat using rifaximin to help reduce the symptoms of symptomatic uncomplicated diverticular disease. And that's really important, and maybe rifaximin has a particular use in these people with diverticular-related IBS symptoms. In fact, diverticulosis maybe is like a biomarker that can help guide us towards antibiotics versus other IBS-type therapies. It also was statistically significant in reducing diverticulitis, although the number needed to treat was much higher at 50. Now, what about fiber and diverticular disease? Well, we've all learned in medical school, fiber can help with motility and help reduce pressure on the Taenia coli and on the muscles and all that stuff. Well, actually, recent studies kind of call into question whether low dietary fiber is truly a risk factor for diverticulosis or whether interventions can truly modify the risk of diverticular complications. The data in SUD, in particular, are relatively limited, kind of small, uncontrolled retrospective studies. So we don't have a lot of data in SUD. Now, this is one study looking at adherence to a healthy lifestyle. And they found in this study by Lisa Straight and others, Andrew Chan and Po-Hong Liu, they did find a lower risk of diverticulitis among men. So this was a study where they looked at different lifestyle interventions, reducing total meat intake, dietary fiber, physical activity, and so on. And they actually did find that these were associated statistically with a lower risk of diverticulitis, not necessarily diverticulosis, but diverticulitis. And here is sort of the if you add up the total number of lifestyle factors, more seems to be better. So somebody that watches their diet and take fiber and exercises and is not obese, you add all those up and they do seem to have a lower risk of diverticulitis. So that is some evidence that there may be a benefit, despite what I said in the last slide. It's rather controversial still, but this study does still suggest there's a role for doing these good things. Now, I want to end with this study from Lisa Straight. This is a very famous study from JAMA that looked at nuts, corn, and popcorn consumption and the incidence of diverticular disease. It actually found no relationship between eating these things and risk of diverticulitis. This is important because we often tell our patients to avoid seeds, avoid nuts. I think hopefully the message has gotten out now that that's not really necessary based upon this study. And people should be able to liberalize their diet a bit. And then finally, is fiber really helping reduce symptoms? I mentioned before the risk of diverticulitis. We really don't know, but we do know in IBS at least, based upon a meta-analysis here looking at both soluble and insoluble fiber, but they found in general that there is a tiny little benefit with a number needed to treat of around 11 for reducing symptoms with IBS. So if we can extend those data to SUD, maybe there's some benefit there as well. Finally, tricyclic antidepressants, we have no evidence whether that helps with SUD. We do have evidence that it helps with IBS with a relative risk of 0.68, number needed to treat of 4. So once again, we have to extrapolate from IBS data to decide if we want to use tricyclics for this sort of form of IBS where there's diverticulosis. So I'm done with the talks. Here are some take-home points. And what I really want to leave you with is, first of all, the risk of diverticulitis really is small in people who have asymptomatic diverticulosis. Although younger patients, the risk goes up a little bit. Diverticular disease really is almost like a chronic medical illness in some patients, not just an acute disease managed by surgeons. So we need to be aware of this condition as gastroenterologists, be aware of SCAD, be aware of SUD, and think about post-diverticulitis IBS. And amongst the different treatments for SUD, it appears that antibiotics is most effective. So with that, I want to thank you again for the opportunity to speak today and for participating in this terrific conference. Appreciate the invitation. Thanks again.
Thank you very much, Brennan, and hopefully you and Bill will come up on our transcontinental discussion in just a moment or two. Just to show you the impact of distance on weather. It's 37 and cloudy in Ann Arbor, where Bill is. It's 66 and sunny here if you were outside. And it's 86 and sunny in LA. So
Wow.
the weather is pretty diffuse around the country as well. All right, well, let me start off with some of the questions that were directed towards me. Again, if you have any questions for our other speakers, just fill out a card and the ladies will be around to pick that up from you. So here's the first one. A hospitalized patient with a negative C. diff result, should that be confirmed as negative before doing more of a workup? And the answer, I think, is probably no. If you get a reliable study in somebody who is in the hospital with it and has developed diarrhea and it's negative, then I would just go ahead and go on with your workup in terms of addressing potential causes of it, which in the hospital setting, you'd have to think about drugs to some extent. Maybe some other medicines they're taking could be aggravating things. Something that you're not aware of, like sometimes people will be taking some laxatives that you haven't written for. You need to really go about a normal workup. But repeating a study that's already been negative but well done doesn't make a whole lot of sense. And your hospital people basically won't do it. They keep track of these things very carefully. And if they get a negative result, it's not like the old days where you do, well, we'll do it ×3 until we get something back. The next question is that for someone who's negative for the toxin, but has a PCR that's positive for C. diff, should they be treated, given a stool transplant, whatever? generally, if they don't have the toxin evident, then the C. diff is not causing their symptom. So if you wouldn't treat them with these other things in that situation, you shouldn't treat somebody who has evidence of the microbiome. Thank you. Oh, good. But no evidence of toxin. All right. Well, we have our co-panelists here, and welcome, gentlemen. It's nice to see you. I already gave the weather report. Although you're using, Brennan, the fake background, but it says it's sunny in LA and 86. So
I'm actually suspended
probably
by a
pretty-
crane in front of the hospital. This is real.
your sound's off. So
Oh, it is? Oh, well,
hit the unmute button,
I'm
Zoom
not
thing.
muted. Yeah, I'm not muted.
Yeah. Too bad.
Oh.
We'll work on the technical features. And let's see, Bill, looks like you're inside, which sounds like a good idea on a 37-degree cloudy day. So,
Yeah, well, a few
all right.
snowflakes.
So let's see. Question for Brennan.
Can you hear you?
Yes,
Can you
you're
hear me
there.
now?
I can hear you now. You're
Oh,
looking
good.
good.
Okay. I
And
was just
sound is
saying
happening.
that I'm actually suspended by a crane out in front of the hospital. So this
Oh, okay. I thought it might be one of your virtual reality things. Okay. So the question for you, Brennan, is which antibiotics would you use for SUD?
Oh, so generally the best evidence is for rifaximin for SUD, based upon a few randomized trials in SUD that actually go back all the way to the 1990s, including studies from Italy and elsewhere that suggest there is a benefit of using rifaximin for symptom reduction with a reasonable number needed to treat. There's even some suggestion it might reduce diverticulitis incidence, but there the number needed to treat is very high and probably not at all cost effective. So I wouldn't use it for diverticulitis prophylaxis, and the AGA guidelines suggest not to do that either. But for symptom reduction, it might be that this is a subgroup of IBS patients where bacteria have a greater role to play, in that the diverticula may be a biomarker of sorts, where suggesting a higher likelihood of responding to rifaximin. So that's based upon a few studies.
Okay. And then in the other diverticular associated problem, when would you recommend surgery for SCAD?
Oh, for SCAD, that's a good question. And I would probably defer to my IBD colleagues on that. But in general, if SCAD requires surgery, you have to wonder if you're really dealing with IBD at that point and not just run-of-the-mill SCAD. SCAD is typically, although not always, but typically self-limited and responds really favorably to medical treatment. And if it's really requiring surgery, you have to wonder, geez, what else do we need to use? Biologics? You know, it's sort of where are we that we have to get to surgery? So I would say it's pretty unusual to require surgery for SCAD, at least in my experience, although I have to acknowledge it's relatively limited for that condition. So I would defer to some others as
All
well.
right. And then the other SCAD question was about antibiotics in SCAD.
Yeah, I'm not aware of good evidence that antibiotics play a role in SCAD. I mean, it, as I said, responds so well to mesalamine, unlike Crohn's disease, but SCAD does respond very well, that typically antibiotics are not indicated. It's not clear that it's really an infectious condition or a microbiome-driven condition, although it might be. But I'm not aware, and I could be mistaken, because again, I'm not a real SCAD expert, but I'm not aware of antibiotic data for SCAD. Again, maybe others are.
Okay. Well, Bill, put on your thinking cap. You were talking a little bit about predictors of response to rifaximin as far as bacterial counts and positive breath tests. Are there predictors for who will respond to probiotics or prebiotics?
Yeah, it's well, here's the thing. There's a lot of discussion around biomarkers as a predictor of response to microbiome-based therapy. So, you know, I talked about how that may be relevant to the low FODMAP diet in regards to using the fecal microbiome, for example, or the metabolome. For rifaximin, it's mostly focused on breath testing or quantitative culture. For probiotics, actually, there's an interesting paper from King's College that was published now a couple of years ago. It's a study that I actually quoted in my my lecture, looking at volatile organic compounds, and actually VOC patterns, pre-treatment VOC patterns, predicted response to the low FODMAP diet, and in a separate group of patients who were treated with probiotics, also predicted response to probiotic therapy. So again, it may be possible to develop biomarkers based on the microbiome or the metabolome that would have relevance to the spectrum of microbiome-based interventions. We're not there yet, but there are certainly a lot of people feverishly working on that at the current time.
Now, those VOCs are the things that dogs can smell, right? So
Yep,
do you think there's a chance
exactly
to train a dog to be a diagnostician for you?
Hey, look, people have talked about, as you know, Larry, people have talked about using dogs to identify VOCs that are associated with colon cancer.
Absolutely.
So
Bladder
why
cancer.
not? Why not?
All right. And another question is, antibiotics don't kill all germs, and they all have their gaps. And we know, I guess, the most about rifaximin for these things, Bill. But do you ever use other antibiotics if rifaximin doesn't work, and see if it might just be a resistance issue or something like that?
So that's actually a much more complicated question than it would seem at first blush. Okay, so the first thing just to say, so everybody in the call, everybody listening and realizes, is that rifaximin modifies the microbiome, but it doesn't actually have that much impact on at least the measurable elements of the microbiota, or actually the microbiome, the fecal microbiome. So for example, there are now multiple papers, including one of which I'm a co-author on, that shows that short-term treatment with rifaximin actually doesn't have that much impact on measurable microbiome. So it really does just modify things. It doesn't dramatically change the microbiome for rifaximin. Now, the question that you asked, are there other antibiotics potentially beneficial? We really don't know. We do know in IBS. We really don't know in IBS. We do know that there are multiple other antibiotics which have been used for bacterial overgrowth. So ciprofloxacin, amoxicillin clavulanate, tetracycline, trimethoprim sulfamoxazole, metronidazole, all those antibiotics have been used for bacterial overgrowth. What we don't know is whether any of those antibiotics are beneficial for IBS. And so we just have to make that distinction and not conflate the two, until we have evidence to say that we can conflate the two.
I guess Mark Pimento was big on neomycin when he was first starting some of his work in this area. Do you ever resort to that?
Yeah, so that's a really important question, and it's a really important point to make. So neomycin for bacterial overgrowth actually doesn't work very well. Where Mark uses it a lot is in combination with rifaximin for IMO, that is intestinal methanogen overgrowth. Remember that methanogens, predominantly Methanobrevibacter smithii in humans, is not a bacteria. It's actually an archaea. So it's inappropriate to use the terminology bacterial overgrowth as it pertains to elevated methanogen levels. So IMO is probably a more accurate terminology, intestinal methanogen overgrowth. And in IMO, neomycin combined with rifaximin seems to be the preferred therapy based on only effectiveness, unblinded effectiveness trials from Brennan's institution, from Cedars. Mark has conducted those trials.
Okay, Brennan, another one for you. I was intrigued by that age versus chance of developing from diverticulosis to diverticulitis graph. And eventually those 40-year-olds become 60-year-olds with diverticula because the tics don't go away. So it suggests that there's something different in the initiation of the problem rather than just being old like me. So did you have any thoughts about why those age cohorts differ like that?
Yeah, that's a really good question. And I don't have a good answer, and I don't know if anyone does. It does suggest that there's something maybe biologically different about diverticula that form at an early age than at a later age. Whether it's more likely to be genetic maybe versus, dietary, although the literature with diet and diverticula is also very messy, and it's quite unclear if that itself has much of an impact on formation of diverticula. For example, fiber content in the diet, which we all learned probably in medical school, relates to formation of diverticulosis. That's also not really at all clear. So there's a lot of uncertainty around this. Where it might have clinical relevance, firstly, is to just simply know that the risk of diverticulitis is higher when diverticula are discovered at a younger age. And as I said in the talk, it's not just because they have longer to live, it's per unit time, it accelerates faster. But the other might have relevance for planning surgery, because although it's really still unclear when to do surgery, if a young person has diverticulitis, well, we know they're probably more likely to have recurrent diverticulitis throughout the rest of their life compared to somebody with new onset diverticulitis who's 73. As opposed to somebody who's 43, let's say. So that doesn't unto itself mean you need to do surgery, but it certainly sort of lowers the bar, I think, lowers the threshold to do surgery if somebody's having recurrent disease earlier in life. So I wish I had a better answer than that, but those are some thoughts I have.
Yeah, well, I think that goes along with the colon and rectal surgeons say, not based on any evidence, but just on their experience that diverticular disease tends to be more aggressive in younger people.
Mm-hmm.
They get more of the complications and problems, so they always are, anxious to operate on them at an earlier stage. Okay, here's another question for you, Brennan. Often I find what grossly looks like inflammation in areas of diverticuli during a screening exam, with the patient having no symptoms and biopsies often not showing histologic inflammation. What is this?
Yeah. Well, we know that the PrEP itself can cause erythema in some patients. And in fact, I remember, Bill, you published a study, as I recall, in IBS patients that found a higher prevalence of patchy erythema of unclear significance on colonoscopy compared to controls without IBS. Not that that was exactly the question here, but that study comes to mind. Am I right about that, Bill? Just before I...
Yes, that's correct. Basically, we just found non-specific erythema and in some cases, even some low-grade inflammation. So, a little bit different than what we're talking about, but yes, that is correct.
Yeah, so what it has in common is sometimes we come across this erythema, we don't know what to make of it. It is interesting that it seems to be a little more common in IBS patients. I'm not as sure whether that's more common in diverticulosis patients in general than, or IBS patients with diverticulosis. But anyway, I don't know what to make of that either. It could be PrEP effect, it could be there's low-grade inflammation, and if they don't have any symptoms, it's like, if a tree fell in the forest and no one heard it fall, did it fall? I mean, it's sort of a philosophical question. So there's a little erythema in there. Patient has no symptomatology. What difference does it really make? I don't know. It could be a PrEP effect, or it could be some very early low-grade inflammation that's just not going to progress.
Yeah.
Do you have any thoughts, Bill? Or
I do. Do you guys mind if I make a comment here? It's,
please.
So I don't know if you saw the paper that was in the New England Journal last week. It was a phase 2 trial of a novel compound that actually targets a receptor, Siglid receptor, on mast cells. But it reported a really surprisingly high rate of EG and EOD, eosinophilic gastritis and eosinophilic duodenitis. And there are also groups now starting to report that that IBS patients have a surprisingly increased rate of patchy eosinophilic infiltration in the colon, Now nobody knows exactly what all this means yet. The really interesting part, though, is that this targeted biologic for mast cells seemed to improve symptoms in patients with this EG-EOD. So, another potential part of the story may have something to do with eosinophils and mast cells, which we've been talking about in IBS for a very long time. So, just another interesting thing to keep your ear to the ground on that might turn out to have relevance.
Yeah, that's really fascinating, and we're thinking about. I think in this case, the questioner was asking about asymptomatic, but that's really interesting. I still think that may have something to do with that patchy erythema that you discovered too.
Yeah, I think so too.
Yeah, Bill, we've all heard the stories about if you're going to have a fecal microbial transfer done to you, you should get it from a skinny person so you can lose some weight. Is there any evidence about the bowel habits of the donor being transferred to the recipient? Sort of like those old science fiction stories where the murderer's hand was transplanted and then the guy couldn't stop stabbing people, where you would inherit or get the traits of the donor as far as your bowels went?
Yeah, I'm not aware of there being evidence in that regard, although let me just say that I'd be highly concerned about getting microbiome from a really constipated patient, for example, or a patient with significant diarrhea as well. I think that it's possible that either the microbiome or the metabolome associated with those changes in the microbiome could be transferable, although I'm not aware of clear evidence to support that hypothesis. I don't know, Brennan, if you do by any chance.
No,
want to put
yeah,
go ahead, Brennan.
Somebody should study this. It seems very, very.
Well, it seems like you could put a methanogen in somebody who has diarrhea and
sure.
be like a permanent antidiarrheal.
Yeah, but you might even swing them to constipation. We've all seen that happen before as well, right? I mean, so I think we're going to have to be thoughtful and really careful about making this simpler than it really is. Like I think we're at that stage right now where it's kind of like, well, if there's dysbiosis, and let's just throw something else in and make it better. It's a lot more complicated than that. And I think that's very much what we're seeing, for example, with the FMT data in IBS, right? I actually think that there will be a role for FMT in IBS. I just don't think that the role is, again, just sort of thinking that you're going to throw somebody else's microbiome into a patient with IBS and it's going to make them better. I just don't think it's as simple as that.
Yeah, I couldn't agree more with that. As an aside, I mean, we prescribe sometimes tricyclic antidepressants and SSRIs, SNRIs to our patients, and we don't always think about, wow, what are the implications of actually getting off of that medicine? What are the consequences of withdrawing from a tricycle? I mean, some people get stuck on those things because they can't get off without vertigo or disequilibrium, and we don't think about that stuff. That's a completely different situation, but FMT is starting to feel a little bit like that. We need to get a little bit smarter about what we might be inducing, even if we're providing short-term benefits. Are there long-term consequences? Not that it's still a fantastic and incredible treatment, but something we need to keep learning about clinically.
But Larry, I thought your talk was fascinating in that regard. The way I didn't realize that people were going to more designer FMT, like in the C. difficile area. At least that's what I thought I heard you saying.
Yeah, well, I mean, people talk about a lot of things. I don't see much data. That's the problem. Yeah. Well, speaking of the C. diff again, a question about if fidaxomicin fails, what would the next treatment be? Well, if they hadn't had vancomycin, you probably would try that next. But eventually you'll probably end up with a fecal transplant on that patient if they're not doing that well. And then there's another question here for Brennan. Is there any relation between the number and size of the diverticula and the symptoms that you're talking about?
Yeah, that's a great question that has not been carefully looked at, although we did look at that in our study, not looking at symptoms. We were looking at the incidence of diverticulitis, and we looked at the number and size, and we also looked if there were ticks within ticks. you know, sometimes you see those really complex ticks where there's a tick within a tick. We were unable to find a relationship between the number, size, and distribution of ticks and the risk of diverticulitis. But I'm not aware of a study looking at the relationship with SUD, in SUD, or symptomatology. So one may exist, but I haven't seen it.
Yeah, I think that would be really interesting to find out, was you colonoscope some people and they have 1 or 2 ticks, and then there are others who have countless ticks.
That makes sense.
I think it would be different. But. All right, well, our final question is a very topical one. Any data out there on C. diff risk in COVID-19 patients? And the answer to that is no, there's no data. Again, it could go any way. I mean, these are incredibly sick people who, if they're not immunocompromised when they come in the hospital, probably become that pretty quickly, especially if they're given huge doses of steroids like they are. But they're also in environments that predispose to sharing organisms. But on the other side, people are being hyper vigilant about cleaning, so there may be less risk. So I think it would be great to see what the data is on that eventually. All right, well, we've run out of questions, but that's fortunate because we've also run out of time. So it's time for us to take an evening break. For those of you who are here physically, you can join us for the welcome reception out in the lobby. For everybody, including our virtual attendees, please come back tomorrow morning at 8:20. We'll start then and have a wonderful day of learning ahead. So thank you all for coming. Have a wonderful evening.